Good afternoon, everybody. Welcome to the Inherited Arrhythmia component of this first Rare Cardiac Diseases conference. It's a great pleasure to have you here. We've tried to make an exciting agenda. We've got some fantastic speakers here from around the world, including Saudi Arabia. So Dr. Alqarawi will be joining us later. We want to make this interesting and interactive. What we would ask, please, for questions is that we're going to try and do that as a panel. So at the end of the 3 initial presentations, we'll have a panel discussion. If you'd like to ask questions, it's often easier for us to just to facilitate that if you can put a message into the chat. So you can either type your question directly or just say in the chat that you'd like to ask a question. And that means first come, first serve. It's much easier for us to see who wants to ask a question. Once we've done that, we can then unmute your microphone and then you can ask your question directly if you'd like to. So our first presentation is going to be from Judy Rutberg. I'm going to pass you over to Dr. Green and he's going to introduce Judy for us.
Thank you, Simon. Can everyone hear me? Can anyone see me? I think you can now. It is my pleasure to introduce Julie. Julie is a genetics counselor who really has over 20 years of experience with genetics counseling, including being the past president of the Canadian Association of Genetics Counselors. Julie started off at Johns Hopkins at the beginning of the inherited arrhythmia world there with the arrhythmogenic right ventricular cardiomyopathy study. And then we were lucky enough to get her in Ottawa in 2005, where she has continued to show her expertise in areas related to cardiac arrhythmia and inherited arrhythmia. Now she's also doing some cancer genetics. She built the bridge between the clinicians and the coroner's office, and we continue to cross that every day. And it's been wonderful. I will say, I want to add in that last year, she was awarded the Achievement Award from the Canadian Heart Rhythm Society for allied health professionals, and it was greatly deserved. And Julie, go ahead. Great to have you here.
Thanks so much for that introduction, and thanks for allowing me to participate in this first event. It's really fantastic efforts to bring everybody together. So I did want to say at the beginning that I don't have any disclosures. As Dr. Green was saying, I'm working in cardiology for over 20 years. Is everybody else hearing a feedback or is it just me? Okay, I think it's resolved, thanks. But I did want to sort of place myself in my experience is primarily in arrhythmia and cardiomyopathy. So adult cardiology obviously is a large area, even amongst cardiac genetics. And for over 10 years, it's been at the Heart Institute, which has allowed me to work side by side with the cardiologist, Dr. Green, and now Dr. Hansom as well. And that's really been a fantastic place to learn about these phenotypes and understand all the nuances about the cardiac conditions and how the role of genetic testing fits in with the care and diagnosis as well as the research. The other thing that's important to know is as well as I volunteered for a number of years with the Canadian SADS Foundation, speaking at several of their patient conferences and contributing to videos and handouts. And I just feel like this is also a very important role that a lot of us play when we're thinking about the role of genetic counselors with patients. I often describe myself being a master's trained is on the one side, I've got patients and their family members, and then I sort of sit in the middle, and on the other side is the physician in the laboratories, and I'm hoping to translate information back and forth between the two. So in terms of the thinking about rare, I was thinking about that word a lot over lunch break because we had talks this morning talking about defining what is rare. And, you know, in genetics, it's where all genetics started was with these rare conditions. And there was no such thing as population genetics years and years ago when I first trained. But now in cardiovascular genetics, you know, our population genetics or our common conditions are things like over here, familial hypercholesterolemia, which is definitely not a rare disease, but it is one of the cardiovascular conditions that now has increased use of genetic testing and identification of patients, because there are drugs newly on the market, and a realization that this is really a public health issue, trying to identify those patients before they develop severe coronary disease. Similarly, in the cardiomyopathy world, hypertrophic cardiomyopathy would not be considered a rare disease. It has too high of a prevalence, probably close to 1 in 200, 250. And again, there's now medications coming on market and an increased awareness that trying to differentiate the types of cardiomyopathy, because amyloidosis is a different medication, for instance, than sarcomeric causes of cardiomyopathy. So there's an important role for genetics there. So those are the not so rare at this end of the spectrum of this slide here. But the rare ones are down here, things like Marfan syndrome, long QT, Brugada, which are, of course, are the inherited arrhythmia conditions, would all fit into this sort of area. Marfan syndrome, I should note for others who are attending, is a separate topic today, this afternoon. Concurrently, one of my coworkers, Dr. Julie Richet, is giving a talk about genetic aortopathies. So that fits under the rare umbrella as well. And also there's other talks going on about neuromuscular, which also contains a lot of genetic conditions. So those are two that I'm hoping to listen to those recordings after the conference. Getting back to our inherited arrhythmia conditions, even though individually these are rare, when you start adding in addition to long QT, Brugada syndrome, short QT syndrome, all of these, they start stacking up so that they're rare. It's more common if you add them all together. So in our clinics, with the inherited arrhythmia clinics, we can fill up a clinic easily with a number of patients who either already are diagnosed, or there's a potential because of either their symptoms or their family history for this. So the other thing to keep in mind is that, these are often, with these rare conditions, realization that they're underdiagnosed, right? When I live in this world, so thinking about inherited arrhythmias all the time, I forget that a lot of the world, even amongst cardiologists, don't think about these conditions every day. And certainly all those family doctors out there aren't thinking about them as well. And so for a long time in genetics, we've always had this realization that we have to educate those other providers and make them aware of these conditions and make sure that the appropriate patients are referred to our specialty clinics. Once they get to our specialty clinics, of course, then those are the rare situations where we have that collection of specialists that are available. As Dr. Khan was talking about earlier today, each of our clinics individually doesn't have enough patients, say with Brugada syndrome or short QT syndrome, in order to put together a clinical trial or even help describe the natural history. But if we collaborate together across the country or internationally, then we have enough data that we can really move forward in this field. And those collaborations, of course, require a lot of different expertise. And as Dr. Green was saying, in addition to the cardiology and genetic counselors work, I've been working as well with, over the years, with the coroners and the pathologists, because they have a lot to add to our field and our understanding of these conditions as well. And then, of course, there's all those other medical healthcare professionals that play a big role for those patients as well. We used to think about, in terms of inherited arrhythmias and cardiomyopathies as two very distinct different types of conditions. And our clinic, in fact, was always called the Inherited Arrhythmia Clinic, with these types of diagnoses being the most prevalent. But slowly over time, we've seen more and more of these cardiomyopathy patients, and the realization that there's more of a blurring, so perhaps overlap for some of these conditions. Some of these cardiomyopathies, their first indication that they have the condition is actually an arrhythmia long before they show signs of a structural heart disease. And in other cases, such as CPVT, there's always been questions about whether or not there is some structural heart disease that might also be present. So distinguishing these from one another isn't always as easy as we thought. And, you know, most of these conditions are dominant conditions. And so I think there's been a history of thinking, well, it's easy to pick them out. You're looking for someone who's got a family history of these conditions. And then you've either got the structural abnormalities, something that's your building blocks, or you've got your electrical problem, and we can differentiate which we're going to test for what we're talking about. But it's not always so simple. I think we've realized over the years is that the more we learn, we realize that we always knew what the tip of the iceberg looked like, that the most severe end of the spectrum, but there's actually a lot under the waterline, a lot more uncertainty about some of these diagnoses. And even for these rare conditions, the amount of literature and research actually over the years has been tremendous. And there's a lot to keep up on if you're trying to work in the area of inherited cardiomyopathy, to read both the genetics literature and the cardiology literature. One of the things I wanted to make everybody aware of were two resources I've just learned about this week, actually, which I think would be a great addition to what we have for our teams. And both came from the Northwestern University in Chicago and the Center for Genetics Medicine there. One is that they have now a database of searchable for cardiogenomic guidelines. They have going back to 1991, and these are all different types of cardiac conditions, everything from guidelines that have been written about the identification of congenital heart disease, valvular abnormalities. But it's a nice resource. I know that I have a huge amount of files on my computer to keep track of all the different papers that come out. But this looks like a good resource for me to tab, to bookmark. And the other one is a nice collaboration that they have done with the Jackson Laboratories in the United States as well. And they've come up with funding for a free online course that's meant for cardiology clinicians. And the title of the course is Integrating Cardiogenomics into Clinical Practice. And this is a case-based, it's described interactive modules that are available for credit. And they're just in 1st of February released the first module, which is red flags and patterns in inherited cardiovascular disease, which is right up the alley for all of us who are trying to educate our colleagues about the rare inherited cardiomyopathies and arrhythmias. Like I said, a lot of patients don't get to our clinics because their healthcare providers aren't aware. And so I'm hoping that these tools will help to make other healthcare providers more aware, and as well as teach some of the kind of kernels of genetics, because a lot of other healthcare professionals might not have had as much in-depth training about genetics. And it's really helpful if they are involved trying to figure out who to refer. It still happens today where I have patients that come to me and tell me that they really had to fight to get a referral to genetics because they already have a diagnosis of their cardiac condition. And their doctor says, well, we know you have long QT, for instance. Why do we have to do a genetic test? So they don't understand that this test information will make it much, much easier to screen family members. And in fact, they are the appropriate person to be referred, not the unaffected family member in that case. So it's an important point. Another important point that I think is often, underrepresented when we're trying to think about inherited arrhythmia conditions and why it's not always easy to put together who's affected and what this family history in front of me looks like. As I mentioned, most of these conditions are autosomal dominant, but an important concept with this is that with autosomal dominant adult onset conditions, there's both reduced penetrance, which is whether or not you actually see effects of the gene or not with the off position. And if it is in this penetrant on position, is how severe the expression of the condition is. So for instance, the proband that we see, the person who has that sudden cardiac arrest or severe arrhythmia at a young age, they're showing signs of the condition and they're on the severe end of the spectrum. They may look like they have no family history, and it's possible they could be the first person in their family affected. But equally, there could be others in the family who show very low expression of the condition and just have not yet been identified. And there could be others who, in fact, just do have the gene, they're genotype positive, but it's not penetrant at all. And so this makes identifying those, less severe cases, the milder end of the spectrum, much more difficult with in our field. And so I think that inherited arrhythmia clinics, having the clinicians, whether it be a genetic counselor or cardiologist, be aware of this and be thinking about asking questions that may seem nosy or not ones that are maybe typical in other cardiology clinics. We're not just looking at the patient in front of us, but we want to know a little bit about their family. How did they die, for instance, or their deaths that were at younger ages, that were accidents that couldn't be well explained, or drownings when someone who could swim. Information about their habits. If your patient in front of you has signs of arrhythmogenic cardiomyopathy, you might want to know how much athleticism they have and how much other family members have had, because that might give you some clues about this variable expression. And as well, increasingly it's where people live and their access to care, and that other people may have cardiac conditions but have never had ability to be evaluated to determine whether they have these conditions or not. So just a few thoughts about thinking about our services to our patients. And this is something that's definitely going on in Ontario, in that we're looking at how cardiac genetics is being provided across the province, and how different types of services could be improved. When we talk about sources of variability in cardiac genetics, I really love this figure that was published in a great paper in 2021. This was about precision medicine and inherited cardiomyopathies. And making the point is that you can start with your genotype. And you can think that, well, gosh, now I know that this is due to, say, the desmoplakin gene, therefore I think I know what the phenotype looks like. But in fact, there's so many other variables that play a role into what that phenotype could look like. And those can be divided into the genetic background with other rare mutations or common variations in the genome that might be playing a role. And this is the type of work that, we're hoping eventually we'll have things like polygenic risk scores in our field, where we'll be able to take an enormous number of genetic markers and be able to say something about what the severity of the disease will look like in terms of the phenotype. We're far from that right now, unfortunately, and most polygenic risk scores right now only add a little bit more information than what we can glean from the family history and our knowledge of those rare genotypes. And there are also, of course, all these environmental factors, other conditions that play a role. So for DSP, is a gene that can be found in the left ventricular dysfunction, but also raises the risk for arrhythmias. But in someone who has, ongoing hypertension and coronary disease, trying to differentiate what's related to the DSP and what's related to their environment can be difficult as well. I think for decades, I've been saying to patients, especially when they come for predictive testing, meaning that they have a family history and they want to know if they're going to develop the same condition, do they have the same genotype as their family member? is that, this is only one small piece, knowing their genotype, that we don't have a way of measuring these other genetic markers and environmental factors at all. And so it would be great in the future if we have a great algorithm that can put together all of this information and then spit out a number that's meaningful for that individual patient. And that's really that type of precision medicine that we've been talking about for years now, and we're still not quite there yet. I think the more we learn about genetics, the more we realize it's more complicated than we thought. Another thing that this figure reminds me of is that there was some discussion this morning about, could we just start with genotype for some of these rare conditions? That maybe, if we had people, there's been talk about population-based genotyping, that maybe every person when they turn 18, or some people would say when they're born, get their genotype, and we would have all of this prognostic information about what they were at risk for. And there's a lot of issues, everything from privacy to interpretation to, how we as a society use this information that still need to be grappled with. And so, the small area that we have some insight about this, having genotype first before we have phenotype is coming from what we call the secondary findings. So for those not aware of it, in the American College of Medical Genetics had put together committees about secondary findings when we were doing a whole genome study or whole exome study, where we're looking at an enormous number of genes. We're not targeting it to a panel. And so we can have incidental findings or secondary findings, they call them, in genes that we weren't looking for this information. But the realization is that the information is available to the clinician or to the scientists, the laboratory. And so if they incidentally came across a variant that suggested that the person has a pathogenic variant for long QT, even if they had that genotyping done for a completely different reason, the feeling is that it would be wrong to ignore that information and not provide it, because there is, of course, medical management and implications. It's an actionable result from that genotype. So these types of patients are increasingly popping up in clinics where they had genotyping done for another reason and stumbled upon a likely pathogenic or pathogenic variation. They have no history of themselves of having this arrhythmia condition or cardiomyopathy, but now need some evaluations and struggle with how do we follow them, and do we segregate these variants in the family as well. So there's actually ongoing research in Ontario, looking through our clinical genome, exome sequencing, and the research is looking at the impact of these incidental findings. So understanding what this means for the patient, as well as what it means for the healthcare system when we start with a genotype, before we had reason to consider that there might be a phenotype in the family. So it's, I think, something that clinics are probably around the world are struggling with, trying to figure out, and the data will slowly accrue, and so we'll have a better idea of what to do with it. But there is, of course, a lot of clinical utility and clinical genetic testing available. Again, from the standpoint of working in cardiology and genetics in Ontario, we have had the access for a number of years to provincial laboratory testing for these conditions, as well as the option to refer out of province or out of country for additional testing as well. And so these detection rates are ones that are, some of them have quite a range of detection, and it depends on which study you look at, how long ago, and how they selected their patients. We've long had the idea of sense that, the younger a patient was at the time of diagnosis, whether it was adulthood or childhood, as well as the presence of a positive family history, and the more severe a phenotype there was, the more likely you were going to find a disease-causing variant. There was a recent paper from a large inherited arrhythmia clinic in Australia that looked at their data and was able to say from the clinical standpoint that this is in fact what they found, was that those characteristics were more likely to result in positive results. A lot of previous studies had reported from the laboratory standpoint where they might have less complete clinical data, for instance. What this means practically is that, when you have a test that has a detection rate of nearly 75 or 80%, such as LongQT, is that you can use a genetic test to help rule out a condition, and you can be pretty confident if you don't find the variant, and especially if a patient had a low, pre-test probability that they had LongQT, you can feel pretty confident that that is valuable information, even if the test is negative. Whereas for other conditions, it's much less so. So, even, and I tell patients all the time, if you have a positive family history, and here with showing from one generation to the next, even in these families, if they say it was dilated cardiomyopathy, our test positivity is probably only about 40%. So if we can't find it in those families, where it's clearly genetic, the test really, it's not negative, it's inconclusive. It hasn't been able to find the variant, but there must be one that's running in the family, or more than one. So in someone who doesn't have a family history, if we can't find anything, then we're really inconclusive, and we don't know if it's our test isn't working, or whether our diagnosis that it's genetic is incorrect, and in fact they have another basis for their condition. You also have to consider the pedigree when you're thinking about your test selection. Most of the laboratory testing that we have in Ontario does not include the rare autosomal recessive causes of some of these conditions. We do test for some of the autosomal recessives, but there are others that are more rare and therefore are not currently on panels that are in province, and would be better tested, those families, at the different test out of province. So in addition, I would say that, knowing your panel is important. For instance, in Ontario, again, our HCM, for instance, panel at CHIO is really geared for adult onset hypertrophic cardiomyopathy. And so if there's pediatric onset, this is not the best test. There are other genes that we definitely don't have on the panel that would be important to test. So test selection is really important, and putting it in the context of your patient, and putting all the information together to be able to interpret it for that patient, to know what the next steps are. There's definitely, lots of utility for genetic testing. There's no doubt about it. Helping to confirm a diagnosis is important, and many times to clinicians as well as to the patients. But we have to recognize that a majority of the times that we may have inconclusive results. Information can provide increasingly prognostic information, knowing that the dilated cardiomyopathy is due to a gene that is associated with increased arrhythmia. It's going to provide risk information and change their medical management, for instance. But as we talked about, there's a lot of other things that we can't provide in terms of a genetic test that has to be taken into account to figure out their prognosis. And genetic testing, of course, is really important in family screening. This is probably the strongest utility for it. But there are lots of different types of communication barriers, everything from our job and how well we push to get those patients information that they can easily share with their families, to literal language barriers and geographical barriers if they can't access services in their own local area. So there's, I don't know that as a con, it's just a limitation, I guess, for what we can do. In terms of variability, in terms of I often think about this as how do we in genetics and genetic testing make sure that we're selecting the right patient and the right test is an important piece. And if we're lucky enough, we have an opportunity to choose which test that we can offer. That's not always the case, and it's certainly not equal across the country in Canada and other jurisdictions as well. Ironically, if you die suddenly of your inherited cardiac disease, you get a different test in Ontario than if you survive it and you OHIP has to cover your testing. So it doesn't always make sense. And these are things that in the healthcare system that we need to advocate for our patients and to change the services. Another variability, of course, is in the results interpretation, and I'll spend a little bit of time talking about, what we could do perhaps better here, and as I mentioned, the communication. So, there's a lot of genetics genes that are placed onto panels, especially large panels that are from commercial labs. And, we always have to ask, is this gene actually associated with the disease? And these are two different groups. One's more US-based in the ClinGen, but have international compilation, and a number of their publications are in that database that I was mentioning before. And there's also a large group in England, and ways to check to see whether a gene association is valid or not. For instance, this is from ClinGen. ANG2 used to be on all the panels for long QT syndrome, but it has been disputed and probably is not related to the disease. Similarly, it was on Brugada panels as well, and Brugada syndrome, really the only gene that's been considered definitive is the SCN5A. But this gene is definitively associated with intellectual disability and autism, and so it is definitely on panels and will be looked at. And hopefully clinicians will not refer now to these patients to inherited arrhythmia clinics. The other issue is that we increasingly run into, and now that we've been doing genetic testing for over 15 years, is, is the variant interpretation still correct or not? And increasingly, we get these out of the blue faxes from laboratories saying, we've changed the evaluation or reassessed this finding that you have from a patient from 10 years ago, which is a little unsettling because we now have to go figure out how are we going to find this patient, let alone explain what this is. But there's been a huge amount of reclassification over the years. What's in the literature from years ago, it cannot be looked at as being current or accurate for some of the publications that are out there where papers published about genome genetic associations for a small number of patients or small number of tests. A lot has changed over the time. One of the groups that's in Canada and based out in Vancouver, this is Dr. Crown's group who spoke this morning, and Brianna Davis is a genetic counselor, was the lead author on this paper, where they went back and reviewed the assessments for genetic testing and reevaluated the evidence years later to see whether they would change. And what you're seeing here with these orange arrows is where they've gone increasing from something that was likely pathogenic is now clearly pathogenic. And that's fine. That doesn't really make a difference in terms of the patient care or evaluation. But the concern is that there were all these VUSs as well. There's some of them, there is here in terms of like the ones that we thought were likely pathogenic that get downgraded to a VUS. And so now you have people who thought that they had a disease-causing condition, variant, and this explained their condition. And then we come back to them years later and say, we're not so sure we had it right. There might be other things going on here. They might need additional testing. We might not have identified all the reasons in the family for this condition, and that can have huge implications. And this is not just unique to cardiology, but I think it's perhaps a little more prevalent in cardiology because we've had large panels for a longer period of time in cardiology than we've had in other areas. And last little bit here, I just wanted to talk about the fact that this idea of variant reclassification. So I don't know about all the other clinics, but I certainly have an increasing number of patients coming back where it's been 10 years since or 12 years since they've had genetic testing. They might be looking for genetic testing in their next generation. You know, the original proband is now in their 60s, and there's someone in their 30s who tested positive for the condition, but shows no sign of it. And it's really a great opportunity to update the family history and to take a new look at the family from the perspective of both phenotyping, cardiac-wise, because our understanding of these conditions has changed, as well as regenotyping them and checking whether there's additional information that can be learned from newer genetic tests. And so I think that, different clinics have done things differently, but many times we viewed ourselves as sort of a consultation center, not so much a long-term longitudinal clinic. But I think increasingly that we need to remind patients to stay in touch. And if they end up being followed by, a heart function clinic or a general arrhythmia clinic, that they still get referred back to a specialty clinic like an inherited arrhythmia clinic, because there are likely to be changes in our understanding of their condition, our understanding or interpretation of their family history. And this could really have large effects. So I think that that's an important point that needs to resonate in our field when we think about rare things, is that we're a touch point, not just once to make a diagnosis, but that we need to touch again and again, and that there's responsibilities probably on both the part of the patients as well as the clinicians to maintain that contact. And so I just want to hope that those are some helpful ideas and thoughts about where the field, where we are in cardiac genetics in terms of thinking about genetic testing and the roles of genetic counselors and clinicians in this field. There are a lot of different resources out there that are helpful for patients, and the patient voice is definitely important. As I mentioned, the involvement with Saud's Foundation and Dr. Khan had mentioned that with HiRO as well, and also, just making people in our networks aware of all the resources that are out there for patients and for educating each other about these conditions and why they're important. They may be rare, but collectively, like I said, they are an important piece of our healthcare programs and under-recognized, but hopefully we can all work together to raise those awarenesses and for the benefit of our society. So I think I'll end there. I've definitely filled my time, and I believe we're going to hold off questions until after a couple more speakers.
Excellent. Thank you, Julie. Fantastic overview, really good presentation. Indeed, we're going to hold off questions until the Q&A panel. If you would like to ask a question, please just pop it into the chat. It's my pleasure now to introduce Dr. Habib Khan, who's going to be our next presenter. Habib is an assistant professor and a member of the Arrhythmia Service at the London Health Sciences Centre in London, Ontario. He, like me, trained in the UK. He had a PhD through Imperial and now is the lead for the Inherited Arrhythmia and Cardiac Condition Service in London. So Habib, it's great to have you here. Thank you so much, and over to you.
Very good afternoon. Thank you very much for inviting me to this exciting conference on inherited cardiac conditions. So I'm going to be, Julie gave a fantastic talk on genetic mutations and careful thought about what the results show. So here's a clinical scenario that I wanted to go through to kind of give you an example of what are some of the things that we think about, and not only at a point of diagnosis, but later on in life. So let's see if I have control. So that's me. I have only disclosures from honorarium for presenting in CHRS Medtronic. So the case I wanted to talk to you about was a 32-year-old who presented to us back in 2010, a school teacher who's otherwise, very enthusiastic, very energetic, was found by the husband following a loud thud that was noticed downstairs in the kitchen. And unfortunately, this quite graphically described by EMS arriving at the scene and by her husband, that she was on top of her newborn baby, unresponsive. The EMS crew, put on the pads and noticed her to be in VF and gave her a shock. Brought her to the emergency department with GCS3, was intubated with decorticate posture, and probably thought she wasn't going to make it. So I wanted to talk a little bit about HiRO pathways. I know Dr. Kron has mentioned this morning. So somebody who presents with a sudden cardiac arrest, we would be looking at somewhere up here. We obtain rhythm strips. Unfortunately, as you know, probably our center is not the only one that experiences this, but we cannot seem to find EMS strips when we need them. But rule out any reversible causes that would include metabolic, toxic work, coronary artery disease work, and also, very importantly, look for ECGs after resuscitation. Of course, that goes with a little caveat that post-resuscitation, you are going to find revascularization abnormalities. You might find some ST changes. Long QT is one of the possibilities too, and that seems to correct itself once you have gone through the toxic phase of resuscitation. But they'll go ahead with having an ICD implant, and then they finally come into our clinic or get referred, where we tend to go through this long-standing HiRO Casper registry that's been running in most of the centers across Canada. And we go through 12 lead ECGs, Holters, exercise stress test, and 3-generation family history. So that's all good. And once you go through that genetic testing, and then we come to a diagnosis. So I'm going to walk through this first part and then see what we can come up with. So the investigations, of course, you're slightly hypokalemic, but the rest of the toxicology screen was negative. ECG shows non-specific changes. Is going into 3 or 4 days post-resuscitation with QTc of 490. A stress test when she was awake and otherwise well shows an abnormal QT response. She then also seems to have non-sustained ventricular tachycardia on exercise and multifocal PVCs. The rest of her imaging, thankfully, looked pretty good and normal. So coronary angiogram is normal. Left ventricular angiogram I'm going to show you. And then as part of the Casper workup, including the stress test, you get a prokinamide challenge to rule out Brugada. So far, we're doing pretty good. So here is a left ventriculogram. And really, some of the things that we look for in left ventriculograms is Takotsubo, phenotype, LV function, and that's really about it. So over here, I don't see any major LV dysfunction. And of course, you can't really see much on short axis either, apart from normal function. Now, this in hindsight might play a part once we go through some of the presentation. This is an echocardiogram or cardiac MRI of the same patient. And as you can see that this is acute, this is an echocardiogram of the patient. So this is an acute 3 days post-resuscitation. She's still intubated. And you can appreciate, this is not looping back on me, so sorry about that, but you can appreciate that the LV function is not entirely normal. There is some regional wall motion abnormality in the inferior territories and the septum. If you go a little bit more towards the apex, you can see the sort of thickened myocardium at this level, regional wall motion abnormality elsewhere. And in a 4-chamber view, again, the same description of reduced LV function and maybe a little bit of hypertrophy along this region. So subsequently, the patient has the stress test, which I was letting you know about. So this is her resting baseline ECG, and then a stress. Things that obviously caught my eye were, abnormal repolarization, V1 to V3. She does have slight prolongation of the QTc interval at stress, along with this sort of polymorphic or PVC arrhythmia. So because of the long QT at 490, the sort of abnormal response to stress of QTc not shortening, she gets to a probable score of suspected long QT. You come down through this route, and she has a probabilistic long QT Schwartz score of 2 to 3, which I will not dwell into in this presentation. But there is no family history as far as we're aware. She goes to the clinical management, and as you would know, and maybe Dr. Kron alluded to this morning, long QT, generally speaking, they get an ICD in a presentation of a cardiac arrest. Most of the centers would do that. Some would advocate just going for beta blocker therapy. So she gets an ICD, but also gets beta blocker therapy. And then we seem to do quite well. She also has a genetic test. And then this is KCNN1 mutation. I'm not a geneticist, so I'll put my hands up on that. But, you know, someone in the audience might recognize this to be a pathogenic or maybe probable pathogenic mutation. So she gets stuck with this label in 2010. So here I am as a fellow and just transitioning to my consultant position. She comes back 10 years later with progressively worsening non-sustained VT episodes, then that degenerate to monomorphic VT, polymorphic VT, and this is somewhat of the dot plot that we see in an ICD clinic, where you could, well, the electrophysiologist in the group will appreciate that there is a short coupled PVC or a normal sinus rhythm, followed by a pause with then short coupled PVC that induces this polymorphic VT. So hence at that point where we think this is short coupled PVC induced polymorphic VT, so the beta blocker gets increased, but she doesn't tolerate much beyond 5 milligrams. And then the diltiazem increased. Again, there's very little evidence on diltiazem, but nonetheless, we wanted to reduce her heart rate a little bit to prevent the PVCs, prevent the pauses a little bit if we can, and also programmed her ICD to a faster base rate so we can control the ectopics, but also keep the base rate higher to prevent this sort of long, short sequence. Despite that, she had further breakthroughs, and then we decided, well, if this is short coupled PVC, similar pattern, even despite with a heart rate of 70, that we ought to maybe give her quinidine. Now, again, the evidence behind that is about class 2, but it seemed to help only for a few months. So then what will we do next? So this is now me in my second month, you know, quite enthusiastic that I'm going to make a difference to the world. And I get to pick up this case with multiple PVCs, multiple polymorphic VT, multiple shocks. Comes in with ICD storms twice in an admission, gets put on amiodarone, the whole thing. And despite that, we can't really figure out what's going on and why is she really getting that many episodes. So I decide to make it a homework for a weekend to actually go through all of her case and to see where we stand. So if we were to go to the HiRO pathways, this is obviously recently been published. If you're not aware, it's in CGC Open, and you can have a look at it. It's quite good. So the sudden cardiac arrest pathway says, you know, obtain all these things and we get down to a final diagnosis. But one of the caveats to all of this is if something doesn't fit, like a long QT doesn't really behave this way, we should go back. We should go back and review everything again. So that's what I did. So I went back to looking at cardiac MRI and echocardiogram. And this is this is one of the MRI views. I'm sorry, it's not going to play here. I think it's not going to. Yeah, it's not going to. But you can see a little bit of thickening along the lateral wall. And the septum seems okay and the RV is fine. Again, a short axis view, there's thickening along the lateral wall. And what I can appreciate is this sort of degree of darker septum, which appears to be nice and thick, and term I'm going to use it compacted. Whereas when you come to the lateral wall, there is a level of thickness or a darker shade of gray followed by a lighter element here, which appears to be not compacted. And if I was to play this image, this is an MRI, of course, many months after, a week after her arrest. Her LV function is now recovered prior to her ICD insertion, that she seems to have decent recovery of her LV function. If you recall right from the first slides, her LV function was reduced, but this time the LV function is now normalized, and you can appreciate that this area just seems peculiarly abnormal when we look at it from a cardiac MRI perspective. If I was to look at it from a 4-chamber, right before I even play the video, you can appreciate that this thickened septum here does not follow through on the anterior and the lateral wall of the left ventricle. And there is possibly a degree of compacted thinning here, and then a large portion that is not compacted. And when you play it, it becomes quite obvious. So could this be one of the diagnoses? Well, we went on to do a cardiomyopathy panel, and we found that she has a PRDM16 gene mutation. And I'm not going to talk about where it's located, but just to know that this has been labeled as likely pathogenic. So we go to the final diagnosis. Is this the final diagnosis of LV non-compaction? Well, there are multiple genes associated with LV non-compaction. So we came to this point and said, well, great, we have a possible diagnosis. This is 10 years after her initial presentation. And now she's continuously coming back with further PVCs and polymorphic VT. What should we do next? So we took a group approach, had a group meeting amongst us as cardiologists and electrophysiologists, and decided that maybe we ought to give her a chance of an EP ablation. So she ended up having an EP ablation, and I don't have the access to the voltage map today, but what the findings was that there was normal voltage mapping of her ventricle, but at least 20 areas of PVCs that were dominant and very easily induced polymorphic VT with catheters. So they ablated at 3 or 4 points, but then decided after 6 hours of ablation that this wasn't really going to do any difference in the long term, and stopped. Thankfully, since then, which is now 4 months down the line, she's had no further events, and we are at status quo with beta blocker and nothing else. So when we talk about LV non-compaction, this is one of the genomic papers looking at, well, if you were to get all these mutations, these are some of the ones linked with LV non-compaction, what is your likely evidence that you will end up getting LV non-compaction as a diagnosis based on phenotype? And they were looking at it from 2 observers, and they thought that anything beyond this score of 12 would be a strong correlation. So these are the ones that are kind of listed as strongly correlated with LV non-compaction, whereas the others have a excuse me, a moderate link. So with our patient having a PRDM16, she's in the moderate sort of score of having a phenotype presentation along with genotype expression. And here's a really good review paper on LV non-compaction. Now, the reason I brought this up is, well, we've said we think it's LV non-compaction. It feels like LV non-compaction. It's talking like one. Is this really our final diagnosis? And it's important to talk about LV non-compaction because we are getting so much better in terms of our imaging quality to be able to see it on echocardiogram, which is panel A and B. So panel A is just looking at a 2D image with this contraction in diastole and systole, and you'll be able to see the non-compacted layer. But an additional top up to that is if you put on color Doppler, you'll be able to see these color flows of blood pooling through the non-compacted layers. And then, of course, cardiac MRI, if it's readily available, then is something that can also be used. Now, with this improvement in imaging quality, there is a lot more LV non-compaction being diagnosed, and it's being diagnosed based on these criterias. So there's at least 6 that are currently in use. The most common one is Peterson and Chen, sometimes Jenny as well, and it's basically looking at ratios of LV non-compaction to the layer of compaction. There is a slight difference in one's in systole, which is the Jenny criteria. The other one's Peterson, which is in diastole, and is usually based on cardiac MRI. So top 3 of the echo, bottom 3 in cardiac MRI. And when we look at those criterias, there was a meta-analysis done on this. Lots of records that have non-compaction mentioned through, but once you feed through all of the possibilities and the images involved, there's 54 that were used in this meta-analysis. And when you look at the incidence, well, European region 54 and America's 30, and the rest of the world doesn't seem to have it to a degree. Is that just because of access to imaging, or is this truly an issue? Other things to think about while LV non-compaction was really not present in 2000 or before, and all of a sudden we have a lot of it being reported. I think all of that kind of boils down to imaging quality. Now, the MRI that I showed you of this patient was back from 2010. So I would probably fit in this sort of category of, 20–40% of publications reporting LV non-compaction in that sort of literature sense. And then the phenotypes of how they were presenting, was it complete non-compaction of the entire left ventricle, an isolated non-compaction, because it doesn't have to be the entire left ventricular area. It could be just apical, could be lateral wall. And so there's a wide variety of descriptions of how this was presented in terms of search terms. And when you look at cohorts of how they were presented, were these healthy individuals or cardiovascular patients? Cardiovascular patients seems to take a bulk of it, and could that be related to dilated cardiomyopathy as opposed to normal cardiac structure? Athletes also seem to have 10%. There are controls that are 9%. So when you speak to most of our inherited arrhythmia colleagues, they will suggest that it probably runs in the natural population at about 15 to 20%. Now that's a really high number. Now, does that really mean that all of those are going to present with cardiac events? And clearly we don't know yet. If we're to look at the criteria, what were some of the criteria used? So Jenny was 3.5%, whereas diagnostic was with cardiac MRI. If you use the Pearson criteria, that was probably the highest one, and that is what we tend to use. From an echocardiogram perspective, if you had non-compacted compacted of greater than 2, then your diagnosis was correct about 64% of the time. In terms of publications, there has been a tremendous amount of publications. Firstly, obviously, starting off with echo, because that has been our groundwork of most imaging, and now a little bit more in terms of cardiac MRI. And when you look at echo versus MRI in terms of diagnosis and final diagnosis, echocardiogram doesn't really seem to do that well. There's a lot of patients on forest plot here that are described as within normal or not diagnosed, whereas with a cardiac MRI, there's a little bit more split of favoring prevalence of LV non-compaction versus negative LV non-compaction. So MRI definitely seems to be a better test for imaging. And when we look at LV non-compaction and cardiac MRI, quite clearly a large cohort have it. But again, it's the same issue of cardiac patients having a certain percentage, but also present in athletes, also present in non-cardiac patients. So this is where the water gets a bit more muddy. So based on that, I think the take-home message really from today's case was, for me at least, the learning course was always reevaluate the diagnosis if it's not seemingly following the trajectory of your original clinical diagnosis. Think about the significance of us, and Julia rightly pointed out, there is still change between variants of unknown significance or likely pathogenic or pathogenic. The shift keeps to going across both directions. It's always useful to have a geneticist or a genetic counselor always involved in our clinic, and that's what we have here. And with LV non-compaction, I think the real important point is that there has to be careful use of it. Now, we're all humans, so since I've started to look at LV non-compaction, I seem to, for some reason, pick up a lot more, and whether that's just my eye falsely reassuring my brain that this is LV non-compaction and I get a little bit more excited, or is this just normal variant, and that's something that has to be quite carefully scrutinized. So we're trying to develop a radiology and inherited arrhythmia clinic, sort of a group, to make sure that when I look at the cardiac MRIs, that I'm not over-reporting, and simultaneously when radiologists are looking at MRIs, that they're not under-reporting. Because these cases, or the one that I've described, was quite clearly, you could see that there was LV non-compaction on the 2010 MRI. There is more work that's required to see if the genotype, like PRDM16, is that truly a proarrhythmic genetic mutation or not, and we're not there yet. So there is some work to be done on LV non-compaction. But from a resource perspective, the HiRO pathways, I feel, are quite useful. They guide, they're a little bit more reassuring. in terms of your direction of guiding investigations and treatment. And if you're never sure of your original diagnosis, always go back to the drawing board. And I think hopefully this case illustrates that. And I'd like to thank you for allowing me this time to present this really interesting case, and we'll obviously take some questions at the end of the presentation. Thank you.
Thank you so much, Habib. Fantastic presentation. So next up is going to be me. So I'm Simon Hansom. I'm the director of the Inherited Arrhythmia Service here in Ottawa. It's my pleasure to be here today and my pleasure to speak with you as well. I'm going to just try and share my slide. Perfect. So I realised looking at the registrants for this meeting, I realised that there's a wide spectrum of people attending today. So what I wanted to do was to try and pitch this at a level where it be a little bit of something for everybody, but really just to step back a little bit and look more at the diagnosis and management of these inherited arrhythmia syndromes. Now, to cover all of the syndromes, you'd be here listening to me for the whole afternoon, and that's not the plan. The plan really was to look at things. I could have said a HiRO perspective. I could equally have said a Canadian perspective, because HiRO is Canadian, born and bred, as you heard from Andrew Cron this morning. And their recent publication trying to standardize how these patients are assessed and treated across Canada is a huge leap forward for us. So I have no disclosures to note. As an outline, just for what we're going to talk about this afternoon, just for the next 25 minutes or so, we'll have a brief overview of the inherited arrhythmias, but more than that, we'll have a look at some of the challenges in these cases, and there are many of them, and some of those maybe overlap into other areas of cardiology, but some are also unique to these patients and their families. We'll have a look at the delivery of care, how that is done, how it should be done, and talk about things that may be a better system for how we can deliver care most effectively to these patients. We'll briefly mention the Heart in Rhythms organisation, and I know that's been mentioned today as well, so it's good to have that foundation set. We'll have a look at the care pathways, and in particular, we're going to focus on two of those. So Habib very kindly has looked at the sudden cardiac arrest flow. We're going to have a look as a case-based discussion on the Brugada syndrome and the long QT care pathways. So for those of you who are listening who aren't as familiar with the inherited arrhythmias, really, they are a very broad group of diseases. They're heterogeneous. They cover a variety of different issues. So some of them are so-called primary arrhythmia syndromes, but there's others which are called channelopathies and others are clear cardiomyopathies. The issue is that they really account for the majority of sudden cardiac deaths in young patients. And when you look at those particularly below the age of 30, then they are one of the biggest causes of sudden cardiac death. Their incidence, we've had this discussion, and Julie mentioned it again during her presentation about rarity. But actually, if you look at all these together, they affect about 1 in 2,000 individuals. There are variations within populations and within countries, but on average, around 1 in 2,000 individuals as an incidence. Symptoms, unfortunately, only occur in a minority of individuals, and that makes it very challenging to detect these in de novo cases. And unfortunately, that also means that there's a possibility that the first time this is diagnosed is a post-mortem. And that obviously is a catastrophic event that we all want to try and prevent from happening. So sudden cardiac death, as we said, affects the young, but really reaches its peak around the 3rd and 4th decades. So these are very young individuals who are dying. The network of services throughout Canada who specialise in inherited arrhythmia is largely small, although it has expanded rapidly. And again, Andrew Cron mentioned this morning as to how impressive the uptake of HiRO has been to standardise care across Canada. And now we've hit the target of 24. And I think when I was in Canada initially about 4 or 5 years ago, we were at 20. So we're expanding rapidly. And the purpose really of all of that we do is to try and identify these inherited conditions and try and prevent these devastating consequences. It's not, however, without its challenges. And the challenges here are, as I said earlier, some of them are unique to these conditions and others will overlap into other areas. But generally, the asymptomatic state of patients is a big challenge. And with that comes a issue with acceptance of disease. These patients often, if they come to us, some of them are coming because they've been flagged as a relative of somebody who's been detected as having a potentially heritable disease, and then they come to us as a well person to potentially be told that they now have this underlying risk or tendency towards developing a disease that they know nothing about and they have no symptoms of. And accepting that can be very, very difficult. In the cases where we see bereaved families, that clearly has an impact on family dynamics. Separated families also poses difficulties with us in the sense of trying to reach those first-degree relatives to undergo appropriate screening and testing can be difficult when there's a breakdown in communication. The presence of guilt and bereavement also makes things challenging, and particularly when parents come to our clinics having had an event in a child, there's a lot of guilt associated with that. And so we often end up in a situation where we have incomplete family histories, and particularly that's even more challenging when families are overseas or where there's been migration, because often we end up with records from other countries where they wouldn't be as complete maybe as they would be if it had happened in Canada, and post-mortem examinations may not be completed either. Ultimately, we end up navigating in this unknown space where there's a degree of uncertainty both in the diagnosis, but also how that may affect the individual. And these patients then end up having to come to terms with a chronic disease of which they may have no symptoms. The other challenge is just managing young patients, and clearly this does overlap into other areas of medicine, but these are often teenage or younger patients who engage in higher risk behaviours. And one of the challenges of that is that it can be very difficult for us to try and encourage or help them to adhere to medical therapy and to the advice that we give. They're geographically mobile, they're off at university. It's hard for us to keep them under constant review and to monitor their response to medical therapy. And behind all of this, sometimes they come to us in the clinic and we say to them that we just don't know why an event has happened, and that uncertainty for some families can be very difficult as well. So all this really feeds into models of how this care should be delivered, and there's a strong emphasis here on the critical role of a multidisciplinary approach to these patients and their families. And there's four kind of facets that I've highlighted here. From a logistics perspective, the amount of work that has to go into coordinating the care of these patients is huge. There's often a discussion between multiple service providers, coroners' offices, hospitals, labs, both inside and outside of Canada, and that is a huge amount of work. And it's important that work falls onto the shoulders of someone who has the time and the commitment to do it. And one of the challenges we often have is that the infrastructure for these types of clinics is not that robust, and so these jobs and duties fall onto the shoulders of sometimes genetic counsellors, but also the physicians, and that's a huge added weight. So the role of a clinic coordinator really is essential. Beyond that, a specialist nurse also is and in those centres that have them, it's a pivotal thing to have, because they are able to provide that bridge between the patient and the physician and the hospital. And they get to know the patients well, and they can address some of these complex needs that they have. The genetics counsellor, the model that we would certainly advocate, and HiRO would as well, is for the role of an embedded genetics counsellor within the clinic. And really, for us who I'm an electrophysiologist and a cardiologist, and for me to maintain my knowledge of the rapid pace at which genetics has evolved is very, very difficult. And having somebody there who has their knowledge and understanding and ongoing awareness of these changes within genetics is essential, and we lean heavily onto those genetic counsellors. You've heard from Judy today; she's been a fantastic resource to us as well here. And then ultimately, you come down to the physician. Now, as I said, I'm from an EP background. A lot of inherited arrhythmia physicians are from a cardiology or EP background. Habib actually is from an imaging background, and that just brings another dimension into this. But either way, having people who are trained and well versed in how to assess and manage these patients is always critical. So to just look briefly at the Hearts in Rhythm organisation called HiRO. HiRO is now across Canada and involved in most sites, really with this focus on clinical excellence, but also has a huge amount of data, meaning that it's active in research, and that really pushes things forward in the care that we can deliver for our patients and for their families. And there's a strong emphasis within HiRO for involvement of families within all that they do. And what that means is that even at the very high levels of the organisation and the structure, patients, families, representatives are involved at all of those different levels. So not only are there adult and paediatric physicians, but there's also genetic counsellors, the trainees, the learners, if you like, and the admin staff alongside the families. And really, they want to promote this guideline recommended multidisciplinary approach for the care of these families, to try and make sure that we standardise the care that we deliver. Their website's fantastic. There's a really good resources section. It has a toolbox of tools essentially that the physician and the patients and their families have access to, even with templates for letters, which can be very helpful indeed. So we're going to move on just to have a look at the inherited arrhythmia care pathways. And this came out of this issue that really, from our perspective, the last consensus statement for us on the diagnosis and management of these diseases is now over 10 years old. And there's been significant advances in that period of time, particularly in the field of genetics. And it was important to try and update the information as best we could to reflect that evolving knowledge base. So not only that, the care pathways wanted to provide more practical information regarding how to manage these patients, because often that is lacking. Most of us can pick up a textbook or find some literature that would support making a diagnosis, but it doesn't often tell you how to follow that patient up, the ins and outs of the test, which test to do, how often you see the patient. And that's another area that these care pathways help us with. So they serve as an expert consensus in not only investigation and diagnosis, but also the risk stratification and follow-up of patients and their families. And they were developed following consultation across Canada with experts from the adult and paediatric field and with the genetic counsellors as well. And they sought to make pathways for the main inherited arrhythmia conditions. So the Brugada and Long-QT syndromes we will touch on today, but also they made them for arrhythmogenic cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy, as well as CPVT. And Habib touched on the one from the unexplained cardiac arrest, and there's one that exists for sudden cardiac death as well. So from the point of view of Brugada syndrome, it's always nice to start with a case. So I was lucky enough to work with Andrew Cron, and in BC, there's a very high population of Brugada. This was a patient who was 32 years old, who'd moved to Canada relatively recently with his family from the Philippines. And he had applied for life insurance and underwent a routine ECG, but it was ultimately reported as being abnormal with a suggestion of a type 2 Brugada pattern. His family history that came through with a referral suggested that his father had died in his sleep, age 46, but that had been in the Philippines and no post-mortem examination had taken place. So this is where we have a look at the care pathway. Now, it goes against a little bit my mantra of not putting a busy slide on the screen. It's a busy slide, but I can't easily get away from that. The idea with the care pathway is that you really start at the top. You start at these. Let's see if I can show you them. You start at the top here. These red boxes essentially are the ways that patients may present into our service. So if you have a family member of a proband, so it's a patient who has a type 1 Brugada pattern, and then you have cascade screening, they would come to the clinic through this route. If, like this patient, you have incidental Brugada ECG, then you'd come in through this direction. Or sometimes you have somebody who comes in following a cardiac arrest, or they've had an arrhythmic event, syncope, and then they're found to have a Brugada ECG, and they would come through this route. So for our patient in the middle, he's going to come in through this direction. And then your first question really is to try and differentiate from the ECG whether he has a true type 1 Brugada pattern or type 2 or type 3. And that's an important distinction, because we know that most of the risk with Brugada sits with these patients who have an unprovoked, particularly unprovoked, but also a type 1 pattern. So if a patient has a type 2 or type 3 pattern, then it's important that we go a step further and we explore the family history and then make a decision as to that individual's risk. If there is nothing at all from the personal history, there'd be no history of syncope, no history in the family of sudden cardiac death, then really most people would advocate that strong reassurance would be the best way forward, and the patient ultimately would come down here and be discharged from clinic. If there is suspicion from the family history, then that's a good indication for going forward and for arranging further diagnostic testing. Now, this colour of box indicates is throughout all of the care pathways, but would indicate you could do this if you wanted to, but it was not mandating this. So it would suggest that you could consider doing a sodium channel blocker challenge. And the reason it's suggested is because this is not a test that you would do as a standalone test to rule in or rule out. We know that there is a false negative and false positive result that can come from this, and it is not a perfect test, and therefore you have to be careful in which patients you select to undergo a sodium channel blocker challenge. It also depends which part of the world you're in. We use procainamide here in North America. In Europe, you choose flecainide or adrenaline, and we discussed the pros and cons of this with the patient. Ultimately, if they choose not to have it done or it's negative, then again you could be more reassured and then discharge them from the clinic. But the biggest issue is those patients who may have a type 2 pattern but have the ability to have an induced type 1 pattern, because it would suggest that their risk is increased. And if that's the case, they go into here where they would come to the inherited arrhythmia clinic. Now, the exact flow of this is slightly different because it depends on the setup of your own clinic. Within BC, because of the amount of Brugada they have, actually when a referral comes in and there's a suspicion of Brugada, often patients are then diverted directly through to having their sodium channel blocker challenge done before they even come to the clinic. And when they ultimately come through, we then look very carefully at the ECGs during that challenge just to be sure that it is a true type 1 Brugada pattern. When they finally come through to the clinic, there's a standardized approach that's taken for their investigation. So they have their ECGs, including a high lead ECG, which moves V1 and V2 to the third and the second intercostal spaces, because it increases the yield of detecting a type 1 pattern. Signal average ECGs can be considered, but again is not mandated. And then we review the family history and the pedigree, and then make a difference, and then make a decision. Ultimately, we end up coming here through to clinical management, and for the vast majority of people with Brugada, we give them routine advice, and the routine advice is to avoid pyrexia. If they do have pyrexia, they treat it aggressively, and that's because we know that the SCN5A mutation and the channel that's affected responds differently with increased temperature, and the arrhythmia risk increases along with fever. So they manage that well, and if they can't manage it during a febrile illness, they present to a hospital where it can be managed while they're monitored. The other thing that we give advice on is about brugadadrugs.org. We know that there are medications that they can take both over the counter and prescribed that will dramatically increase their risk of an arrhythmic event. And so that's another important piece of information that we provide to the patients during their clinic visit. We also then go on to talk about the role of genetic testing, and in particular, we've mentioned earlier in one of the other talks about the role of SCN5A, which really is the only gene we test for at the moment in Brugada, and we discuss the role of family screening with these patients. HiRO has a fantastic biobank and a registry that we enroll people into, and that allows with future research as well. And then here, this is the question that a lot of people have when they're starting out in clinic. Great, we've made the diagnosis, but how soon do I see this patient? How often do I repeat their investigations? And on this basis, every 2 years, you'd repeat the ECG, both in standard and high lead positions. But also, as Judy was saying earlier, we like to often go back and just review and reflect on the genetic variant classification and make sure there's been no reclassification since that patient was last seen. For patients who have had an arrhythmic event, then often it's a case of secondary prevention device implantation, and they would come down here for ICD insertion. If they go on to have appropriate shocks, then there's a role potentially for the use of quinidine or catheter ablation, and certainly the Bordeaux group have been very active in catheter ablation for these individuals with normalization of the ECG changes. So that's still in its infancy, but is something which over the years may become more common. So we're going to leave the Brugada care pathway there and move over to long QT just for the last few minutes. We're we're going to have another case here. So this is a case of a 52-year-old lady who was seen in clinic. She had a background history of anxiety and depression, and had been maintained on citalopram with actually quite good symptom improvement for the last few years. So she presented because she had reported some atypical chest pain symptoms, and an ECG was performed. QTC at that stage was suggestive of prolongation, with a QTC reported at 495 milliseconds. She had no personal history of syncope, and she had no significant family history of note. And so she ultimately ended up being referred because of concern regarding the possibility of an underlying long QT syndrome. So here we have the same care pathway for long QT, and this is the red box where you start at the top, and this patient is going to fall into the suspected long QT syndrome proband. And obviously patients will come in one of two ways, either symptomatic or asymptomatic, and she's never had cardiogenic syncope or ventricular arrhythmia, but clearly does have QT prolongation. Her baseline ECG, the T wave looked largely normal. When you come along as the first step, this is really critical, and it's important that we remove any factors, any medications that may be reversible and prolonging the QT. And this is not always possible, particularly with the drugs used for treatment of depression and other mood disorders. The vast majority, if not all of them, will have some effect. Some are better than others, but all will have some effect on the QTC. And if patients have been very stable, sometimes we have to reach a decision as to the risks and benefits of interrupting their medication just to improve the ECG appearance. So ultimately, once that's been withdrawn, the patient gets referred through and is seen in the inherited arrhythmia clinic. Now, you might ask the question, well, if it's drug-induced, why on earth are we seeing these patients in the inherited arrhythmia clinic? And there's some reasonable data to suggest that if you take all patients who have what's believed to be an acquired form of long QT, so they're on medications that prolong the QTC, and then you withdraw that medication, about 1 in 4 of those are found to potentially have an underlying congenital long QT syndrome. So it's reasonable that these patients are reassessed once you've withdrawn those offending medications. They then come into the clinic, they have an ECG performed, they have an echocardiogram performed to rule out structural disease, and you take a very careful personal family history. Ultimately, the diagnosis is still enshrined in what's called the Schwartz score. So the Schwartz criteria looks at 3 different aspects, from the ECG through to the clinical history and the family history, and it assigns a point weighting. Now, if your score is 3.5 or above, then what they would say is that you have a higher probability of having long QT. And the reason for that is the specificity when you have a score of 3.5 and above is 99%. The sensitivity is low, around 30%, but the specificity is very high. In this case, her QT remained at over 480, despite withdrawing the citalopram. And so she had a score of 3. So if we take ourselves then through to looking at the flow diagram, she's going to come down here. She's technically at 3, so she's going to be a possible long QT syndrome. And in that situation, that's where you would consider genetic testing. She's possible, but you'd want to sit down with her and have a discussion, ideally from one of the genetic counsellors, about the pros and cons of genetic testing. Ultimately, when we see these patients, the management can, and in most situations, is conservative. So what that would mean is that we talk to the patients again about pharmacological issues, so medications that they should avoid, and there's very good websites and apps that they can use to cross-reference any medications they take to try and avoid medications that may exacerbate the long QT and increase their risk of arrhythmia. There's other lifestyle modifications that would be suggested. So depending on the genotype, we know that in long QT1, for example, that patients more often have events during exercise. However, patients who are medicated on a beta blocker are very, very safe. And actually, the health benefits of exercise versus the risk in someone who is stable and well medicated is very, very low. So general advice for exercise is that they can exercise. That's absolutely fine. The only one caveat usually would be swimming, unsupervised swimming, particularly in lakes in Canada, because if they were to have a syncopal event in the water, they would drown. So the risk is clearly much higher. So we would advise about that. For the vast majority of patients, they would be put on a non-selective beta blocker, and they do very well indeed. So we go slowly with the beta blocker. There are suggestions as to what dose we should use. In most situations, I feel, and I suspect Dr. Green would support that, I feel that it's difficult to get patients onto high doses because they may not be tolerated well. And so we go slowly. We start with a low dose. We repeat the clinic visit a few weeks later. We up-titrate the medication. And we monitor to see how they do. And probably the best test that we have objectively to assess their response is to repeat the exercise test. So exercise testing in the diagnosis of long QT syndrome is extremely helpful, and we haven't touched on that because that's a whole presentation in itself, but there's some very good published data allowing you to use the 1 minute and 4 minute post-recovery QTCs, not only to make a diagnosis but also to help understand whether it's most likely a long QT1 or long QT2 underlying. So repeating the exercise test once the patient has been beta blocked and then looking for a reduction in their target heart rate is a very helpful way not only to prove compliance but also to prove that we're having some beneficial effect. Once we've done that, we're comfortable that the patient's on a stable dose of medication, that they're tolerating it well, then usually we would follow them up on a 1 to 2 yearly basis. And again, we go through the same process of looking for genetic variant reclassification. We also speak to them about family screening. And in younger, particularly female patients, we talk to them about pregnancy. And pregnancy, again, is another important topic in long QT. Very briefly, beta blockers are safe during pregnancy, but we know that their risk of arrhythmic events does change, particularly in the peri-postpartum period, extending out for about 6 months following delivery. And so we would normally see those patients more regularly at that stage and often increase their beta blockade accordingly. We then would follow them, and if they've been stable really for more than 2 visits, then you can often extend the follow-up period. We give our patients medication and we assume they take the medication. We know that compliance, particularly in these younger patients, it is not always perfect, and so we have to be mindful of that as well. Generally, we would strongly endorse compliance with medication. We know that the vast majority of episodes where someone has an adverse event, an arrhythmic event, is often because either they've inadvertently taken a drug, an over-the-counter drug or prescribed medication that's exacerbated things, or they've been non-compliant with their beta blocker therapy. Assuming compliance and caution with other medications, generally they have a very benign course. Looking just at the wider parts of this care pathway, there's also a flow chart here looking at the screening for family members. So that's the cascade screening here, and also those patients who have very borderline appearance who can ultimately be discharged from the clinic. Just very briefly in passing, these are the flow diagrams, one for arrhythmogenic cardiomyopathy, again with the same initiation or route into the clinic at the top here, and then the follow-up at the bottom, and then also one for CPVT. So in conclusion, these inherited arrhythmia syndromes can be very, very challenging. They're not only challenging because they can be difficult cases, as Habib highlighted earlier, they can be very difficult cases to piece together to try and understand the cause, the etiology to it, but also the patients and the families are challenging to manage as well. And really the emphasis should be on the role of the multidisciplinary team, because we are all as dependent on each other for support in caring and delivering optimal care for these patients and their families. The care pathways are a fantastic resource. They're certainly aimed at standardizing care across Canada. They definitely have a role within newer sites that are starting up. Also, maybe in those individuals who are community cardiologists who have patients with long QT and they're not sure about management and follow-up and onward referral. But they also have a role for more the expert end of the spectrum as well, just in standardizing everything that we do. Thank you for allowing me to present. What I'm going to do now is end my presentation here and then pass back Habib.
There are a couple here.
Perfect.
One from Samantha, and it's for you, Simon. In our clinic, she says, we run into a large number of patients with incidental diagnoses of Brugada ECG. No symptoms, no family history, negative genetic tests. So what would be your management of that? Do you follow the same care pathway?
Yep.
And how often would you see them?
Oh, perfect. I don't know where the echo is coming from. It's not from my end. Maybe someone else unmuted.
I believe it might be coming from Dr. Green. I'm just going to mute you for the moment.
Perfect. Yeah, that's better. Thank you. It's a very good question. I would still follow the same care pathway. For us, I think when you look at the ECG, you have to make a decision as to whether this is a true type 1 Brugada ECG. There are a lot of patients that get referred. I saw one just yesterday who's referred with a queried type 2 Brugada ECG. We know that those patients generally, in the absence of any significant family history and in the absence of any personal history of syncope, they are very, very low risk. And most people in that situation would not advocate any follow-up or further testing for those patients. If patients come through and they truly have what looks like a type 1 Brugada ECG, then that's certainly where we would look more as to the role of taking a very, very careful history and also the role of genetic testing to confirm the diagnosis. I think the care pathway that's produced by HiRO still would cover those cases, those incidental findings, if you like. It's not so much in Ottawa. I think definitely if you go to BC, because of the change in population and ethnicity, there's a huge amount of Brugada there. And I was certainly, if you sit with Andrew Kwon and you look at an ECG, you say, wow, that looks like a type 1. He says, no, it's not type 1, there's a type 2. And really have a very, very strict criteria for whether the patient truly has a type 1 ECG or not. Does that answer the question? Dr. Green, I don't know if there's anything you'd say in response.
Am I unmuted?
Yes.
You can hear me.
Yes.
I don't have anything to add to that. Samantha has a question for Julie, and then I have a question for you. So Samantha's question for Julie: how should we interpret changes in variant classification over time, especially likely pathogenic to pathogenic variant downgrades, when it comes to cascade screening in the relatives? Can we say that the relatives that test negative for the familial variant don't require ongoing clinical screening and follow-up?
Yeah, good question. So I think the issue is which categories they're being moved from. So if you're going from a likely pathogenic or a pathogenic all the way down to a variant of unknown significance, that to me is saying that we're not sure we're looking at the right variant at all in that family. And so that does change those people who screened negative for the variant, because we're saying that it could be an entirely different variant that is really the causative variant in the family. So I think that we do want to keep an eye on those individuals. It's tricky. I think it's changed how I have counseled people more recently, in that reminding people to stay in touch with our clinics, to reevaluate it, and to be sure to let us know if there's anything new in the family history, because certainly if there appears to be a lack of segregation where you're not seeing the variant traveling with the condition in the family, that's another red flag that we were barking up the wrong tree. So those are hard conversations. I've had a couple of situations where I've had to recontact people who hadn't heard from me for like 10 years and say, your variant is no longer pathogenic. We had cleared your son years ago, and now we can't say that any longer. And now we have to reopen this investigations again.
Julie, can I ask you a question as well, if that's okay? One of the increasingly common things that we're seeing now coming through to clinic is this kind of commercial influence of genetic testing. And we're having people who are coming through with these likely pathogenic variants who have just been flagged because their workplace offered them genetic testing and they decided to say yes and go ahead. And I can only see this getting worse as the years go by. Do you have any insight into how that should be managed or a different direction it could take?
Yes, I think this is a big issue. People have these incidental findings, and it can happen in a variety of settings, everything from a well checkup type of or a curious patient to situations where there had been a sudden death in the family, and a huge number of genes are checked by the anterior coroners, and sometimes these they are incidental findings. The finding is clearly in a gene that has association completely different than the circumstances or the findings on the autopsy. So I think it's hard to completely ignore those. We have to keep an open mind to them. I'm hoping we can provide some reassurances with our cardiac evaluations in combination with the genetics. But I think right now we don't have a way to completely reassure people if they have a pathogenic finding at this point. I'm hoping that with a number of these instances coming up more often as we accrue this data, we'll be able to have more helpful information about what it really means if it's an incidental finding.
And I think it kind of goes against what we would do in the clinic often. I think we're very phenotype driven. We would tailor our question, the genetic testing question, to what we're seeing in front of us rather than throwing a net very wide and blindly to see what comes back. And I suspect you'd advocate for the same thing, would you?
I've always been more cautious that way, yes. But this is the difficulty as we try to figure out some of the service delivery and the resources that we have. There's conversations in Ontario about our panels being too small and perhaps they need to be greatly enlarged. And the concern is that we're going to pick up findings in genes that we didn't expect to, we don't know how to interpret, or that we find a lot of variants that now we're going to have to follow for many, many years in patients in order to understand, whether they have an impact. So I've always tended towards caution. I know there are others in my field who are more of the idea of, data. All data is good, and we should go cast the large net. But you have to find a balance, I think.
I have a question for Simon, and then I have one for Habib after. Simon, the care pathway doesn't really get into specifically in the long QTs who should get an ICD and who should get, for instance, sympathectomy and other treatments. I just wanted to get your comments on that. I get the sense that too many people used to get ICDs with long QT, but I just want to know what your thoughts are.
Yeah, I think that's a very good question, Dr. Green. Can we just mute you again? There we go. Oh, it's better? Okay, it's gone. Good. It's an excellent question. I think probably if you looked at the trend over the last 10, 20 years, it's definitely been away from ICD implantation. There's always this question that comes up when it's a new diagnosis, when the patient's naive to medical therapy, they've not been tried on beta blockers in the past. The question comes up as to whether, well, maybe if they were on a beta blocker, the event could be prevented and whether they would still need a secondary prevention ICD. I think that's a very good question. The other question then comes in the role of, are there any other adjuncts, any other treatments that we can offer to try and reduce risk for these individuals? We know living with an ICD itself is not without risk, not only because of the complications of the device, but also the risk of inappropriate therapy. and particularly in a young patient. And the role of sympathetic denervation is growing in the argument of should we actually change the order in how we approach this? Should we go for medical therapy, then sympathetic denervation if there's a problem, before we then reach for the ICD? Within Canada at the moment, there are challenges with sympathetic denervation and where that could be done to have an optimal outcome, because it's potentially a complex procedure. So definitely you have to tailor things to what you have locally and nationally available. But I think there is a growing argument now that moves us away from an ICD. People have their own opinions about that within the inherited arrhythmia community, but certainly my personal feeling is I would usually advocate for medical therapy if it's not been tried, strong consideration of sympathetic denervation before reaching for a device, particularly in a very young patient. There are other strategies we have, obviously, with subcutaneous ICDs, where we can try and spare the vasculature in these young individuals. But again, it still involves giving that person an ICD. I think the care pathway, in answer to the other part of the question, it was never to have everything on that one slide would make it particularly messy, and I think those caveats often need wider discussion. And that's the other strength of the HiRO network, is that we work in collaboration with each other, and we always have other people that we can call on to discuss these more challenging cases with for advice as to how we best proceed.
Can you hear me now? Julie put on did you do that in the chat, Julie? So everyone should be able to get the database for the cardiogenomics from Northwestern. Julie put it in the chat, and I think this is going to be a very, very useful tool. So if people see that, they can get onto that site and get the information. I wanted to ask a question to Habib. Your patient has almost certainly phenotypically an arrhythmogenic cardiomyopathy, which is almost certainly left ventricular non-compaction, and you have a maybe gene, maybe a probably gene. And my question is, if you have a family member with that genotype and little or no evidence of the phenotype to the extent certainly that your patient had it, how would you manage that? Very difficult problem.
That's a fantastic. We seem to get quite frequently in most of our other cardiomyopathy clinics as well, not just with LV non-compaction, but ARVC seems to have the same issue. So with her, hypothetically, if she had another family member who had the same gene mutation, we would, under normal flow of patients is, we would tend to follow them up until they were roughly in their 40s or 50s. The average age we're currently using is 45. And I tend to use 2 to 3 yearly echocardiograms with a cardiac MRI every 5 years. Have that access here, unless there is a clinical or a symptomatic change. So if they start describing palpitations, then the MR is 2 to 3 yearly with yearly echocardiograms. So that's the sort of take I have for those sort of patients. Now with her particularly, she does not have any adult family members, but she has children. So we are going to be screening them for phenotype expression first. And then maybe consider genotype with our guidance provided by the genetic counselor that we have in clinic. Dr. Green's muted.
Can you hear me now?
I can, yes.
The patient asks, I have the same gene, and the family of the patient, and what is my risk? I find this the hardest thing, giving a number to risk and comparing that to walking in the winter and ice falling off the roof and killing you that way, because there are so many ways. And how do you manage that in your clinic?
Yeah, so this is a question we do get. The idea behind a genotype that's present in the absence of phenotype, the risk is very low. And I tend to usually say for them to act as if they're part of the normal population. Because the genotype expression does not necessarily mean phenotype, not only for structural change, but also for electrical change. Because we do have some cardiomyopathies that are just borderline mild phenotype, but have a very aggressive electrical phenotype. So if the electrical and structural phenotype are absent in the presence of a gene mutation that's present, I do just reassure them to say they're currently part of the normal spectrum. Okay.
Habib, can I ask you a question as well,
Mm-hmm.
if that's okay? From my point of view, I find non-compaction difficult. I find that you see so much of it. Sometimes you get the impression it may be overcalled. What's your kind of hierarchy of approach to this? Are you calling it as a diagnosis of exclusion when you've excluded all other potentials for these kind of arrhythmic events, or where's your level of threshold?
Yeah, no, that's a great question. So by default, it's always been a diagnosis of exclusion for me, because of the prevalence in the normal population. And I think with much more clearer imaging, we are going to come to that crossroads. In fact, if we're not there already, and I'm seeing that with our local registry, that there is a lot of LV non-compaction being called. But the only fine line where I have more scrutiny is if they have abnormal ECG, because that abnormal ECG cannot be a normal pathophysiology. It has to be something more distinct. So that's where, I mean, we're coming through some registry data at the moment, so there will be more information coming. My main interest is to see if there's LV non-compaction, is there a genetic link that is more electrically aggressive phenotype. So that's what I'm looking for, and that's going to look at, stress testing, Holter, but also left ventricular strain, because that might be an earlier hallmark of phenotype cardiomyopathy. So that's where we're there yet. But in terms of, you're absolutely right, in terms of current, we have the same issue. So after this case that I discussed was the first case amongst my registries. I got super excited. And then, as you would expect, there's now 80 patients on the registry. Yep. And most of them are normal phenotype otherwise, right? So we are going to get to that crossroads. So we're thinking about it hard, about how to approach these so-called normal patients.
And do you see it as a single entity, as a disease, or do you see it as a kind of final common pathway?
I think the way embryologically it's been described is that there is somewhat of a common theme of LV non-compaction during the time of fetus development. Whether these are specific genes that we just find as isolated mutation, or they're part of that sort of hallmark of later presenting with phenotype, because we don't see them in children all the time. So I think there might be a common pathway, but we haven't pinpointed that yet. Yeah, we're not there yet. It'd be good to work together on something like that. Maybe.
For sure.
Yeah.
Would be happy to, definitely. Dr. Green, do you have any other questions?
Any other questions? I have thousands, but so I'm not the right person to ask. I have more questions than answers. I spend a lot of time thinking about over-treating asymptomatics who may have either a genetic or a minor abnormality and have never had a symptom, have never had a problem. The tragic outcomes that are rare drive us more than the excellent outcomes which are common, and we do so much to avoid the tragic outcomes sometimes that I think we create both disease and symptoms. So I don't know the answers. I struggle with this. I'm sure we all struggle with this, because when you have something that has a relatively low risk of happening, but an incredibly terrible outcome, it's hard not to overreact in a person who has no symptoms and a borderline diagnosis, or even a real diagnosis. And I think Habib mentioned ARVC, and we're making progress on what are the risk factors in ARVC, and we're getting better with that. We're not in most of the other arrhythmogenic cardiomyopathies, and it's really difficult. I welcome anyone's thoughts, opinion, including the audience. I don't have any more questions in the chat or in the Q&A, but I'd like your thoughts about how physicians and healthcare professionals react to the potential for a bad outcome.
Yeah, I think that's a really excellent question to ask. From my perspective, I think that risk stratification is challenging. Even when you have an established diagnosis, we don't have robust tools to make that decision, and it's disconcerting for patients because we know that we will get it wrong in both directions. We'll overcall some and give them an ICD, and the other ones we may miss and they have an event before they finally get their device. So I think there is Julia Cadran's done a lot for ARVC recently with her risk calculator to try and work out, or at least have a predictive tool to help us and to guide that discussion with patients, but it's definitely lacking in other areas, and it's obviously an important discussion to have with them. Perfect. I was only going to ask Julie another question. From a legal point of view, maybe not everyone's aware within Ontario as a province the role of disclosure of genetic information, and I think we get asked this by patients a lot when they have genetic testing about the impact it may have if they have a positive result, and about whether that needs to be disclosed. Would you be okay just to give a kind of a brief overview of that?
Certainly, yes, it is a common question. So Canada was actually one of the last of the G7 countries to actually put into place federal legislation that would prevent what we call genetic discrimination. So in the past, patients have had fear that if they underwent genetic testing, that if they then applied to made an application for life insurance or disability insurance, that the genetic data would be used in determining whether or not they could obtain that insurance. So currently, the insurance companies cannot ask for that information, and they're not supposed to use it if it isn't inadvertently in the records that are released. Generally, what we say to all patients is that they should work with an insurance broker, because that's their job, is to help people get insurances. The insurance forms always will ask questions about, do you have a family history of cardiac disease? Most of them are looking for things like early onset coronary disease and familial hypercholesterolemia. They're not really looking for long QT and inherited arrhythmia conditions. But you have to answer those questions honestly, of course. But the insurance broker can make sure that you answer appropriately, honestly, but not giving more information perhaps than is needed. But certainly, the time, and we also say to patients, is that the time to get insurance for life insurance and disability insurance, if you're interested in those products, is when you're young and healthy. That's the general advice. We also point out now many times in our letters that, if you get a new diagnosis, whatever the condition is, and it might be because you were coming to the cardiac clinic for a family history, if you then have your EKG before you see the physician, you now have a diagnosis. And so that's now on your chart. So I think there does seem to be some caution when we're talking to the probands, the index cases, about the implications of their diagnosis for their family members when they go appropriately seeking cardiac evaluations, but it could have some immediate changes if they are diagnosed.
And I think it's one of the arguments people have used to advocate for throwing that net wide. Well, if you get a positive result, you don't have to disclose it. But of course, the subsequent clinical investigation that's done would be disclosable. Yeah.
Yes.
Okay. Perfect. So thank you so much. What we're going to do now is to move on to the next section. Dr. Alqarawi has now joined, I think, from Saudi Arabia. So I'm actually going to formally introduce Dr. Green, which he needs no introduction. But Dr. Green is a friend, a mentor. He has got so much wealth of information and knowledge within inherited arrhythmia, where he's worked most of his life and his career. He's a fantastic person to work alongside. These sessions are always usually the crowd pullers at the big conferences, where we get to hear him speak about ECGs. One of my old bosses, who knew him many years ago, described him as the Yoda of the ECG world, and he doesn't disappoint. So my pleasure to hand over to Dr. Green, and I'm sure it'll be another great presentation.
Thanks, Simon. I'm not sure that I'm Yoda, but we'll give it a go. But I did come to this from the ECG, without question. I was always fascinated by the ECG, and so I'm going to talk about, guess what? The ECG. But how we unmask masked phenotypes. So what we have here is a problem in that we have an ECG which is visible and clearly is good at diagnosing arrhythmias, and yet sometimes some of these arrhythmias are actually unseen, and we have to somehow find a way to see them. So unmasking the invisible, specific phenotype genotype testing for specific phenotype testing for specific genotypes. I come at it from the phenotype, not from the genotype world, and I only got into the genotype world relatively lately in my career. My career is now quite old. Okay, no relevant disclosures except that I love electrocardiography. That's the only one. So, unmasking the invisible, it's what this is about, and it's about the ECG, and we have lots of ways to do it, and we have lots of reasons to do it. And the main reason is that there may be many inherited arrhythmia conditions for which there may be no ECG abnormality at rest, and we may have to do something to bring out the salient ECG features. Those somethings are sympathetic stimulation, and by that I mean exercise. We've largely dispensed with adrenaline testing for long QT. Secondly, a change in lead position, and Simon's already mentioned that, in Brugada syndrome. And thirdly, we can challenge with medications, and Simon's mentioned that already. But let's move forward and talk a little bit about the ECG, firstly in long QT. Next slide, please, Chelsea. Okay, I cannot move forward, and
Sorry,
I think
just give me one
Dr.
moment.
we can see your slide. I'm not sure which one you can see.
Okay, I now see the first ECG slide.
That's it. Perfect.
Okay, I couldn't before. So this is actually from Andrew, and this is the exercise test for unmasking. 51-year-old male with a cardiac arrest, obviously a high risk situation. No other features: normal ventricle, normal coronary anatomy. 4 siblings died in their 40s and 50s of a heart attack. I just want to mention that in the community, when people talk about a heart attack, and especially when they use the term massive heart attack, they often mean cardiac arrhythmia. And, you know, in our world, a heart attack is a coronary occlusion with a myocardial infarction. But in most people's world, it is a sudden cardiac death. So when you do your family history and someone says someone has a heart attack, be very careful to figure out what that is. Next slide. There we go. Exercise test. Now we do a standing test pre-exercise, and I want you to focus on the red arrows, especially lead 2, lead V4, and lead V5. And what we see is, from a normal ECG a few seconds ago, a long QT, and a hump. So we now have a hump on the T wave, a bifid T wave if you wish, and a very abnormal QT just upon standing. This is pathognomonic for long QT2. And if you remember the initial ECG, it was totally normal despite the very, very, very worrisome family history and personal history. And here's the ECG. So you have to do more than just a resting ECG in many cases. Moving on to Brugada syndrome. Here is an ECG on our left and in the expanded panel showing typical Brugada ECG in V1 and V2 with ST elevation, a coved ST segment, and a deeply negative T wave. And that's the classical ECG of Brugada syndrome. But remember that the ECG may be dynamic. And on the left is a patient's ECG who has Brugada syndrome. That ECG in V1 and V2 and all the other leads is totally, completely normal. When I say dynamic, at another time, if you look to the right panel, you see a classical ST segment elevation, T wave inversion in V1 and V2, indicative of Brugada syndrome. V3 has that upward coved or saddleback appearance. So because it's dynamic, if we see a patient and we're wondering about Brugada syndrome and the ECG is normal, we have to do something to unmask the invisible. There are several ways to do it. We use IV drug testing. Simon mentioned procainamide study. We do not have the other drugs that are used because intravenous agenoline, intravenous flecainide, and intravenous pilsecanide are not available in Canada. But we use procainamide. It's probably not as sensitive, but maybe more specific. And I'll show you an ECG of that. Interestingly, another drug, which has primarily been used originally for atrial fibrillation many years ago, I'm probably the only one who remembers that, is no longer used for that purpose, but actually is very helpful in Brugada to normalize the ECG and reduce the risk. So on the left, on the labeled control, we see a type 2 pattern in V2. Following procainamide in the middle panel, we see a classical Brugada type 1 ECG. Again, ST elevation, downward coved ST segment, and an inverted T wave. And following quinidine, we see a completely normal ECG again. So we do have to unmask Brugada if we're looking for it, if the ECG is normal, or if there's a type 2, which is not considered to be standard Brugada type 1 ECG. The other thing we can do is use non-standard ECG placements. This was already mentioned. So it may be transient, and we may have to move the leads higher to bring out the typical coved appearance that we're looking for. This is a 48-year-old man with a family history of sudden death. This is his baseline ECG. And if you look at V2, we see a little bit of ST segment elevation with a saddleback appearance, not a classical Brugada ECG.
Sorry, Dr.
Now,
Green, I just would like to confirm what slide you're on for the audience. I want to make sure that I'm
the one I'm seeing is the one I'm talking about.
Okay.
I don't know the numbers.
Okay.
Because I've got it on screen. I'd have to go off screen show to do it.
Chelsea's on 12.
Thanks, Doctor. Thank you.
Sorry, Simon, Julie, and Habib, whoever's on microphone, are you looking at the same slide I'm describing?
We're looking at a baseline 12 leads of the 48-year-old man with syncope.
Perfect, Chelsea. We're good. So we now move the leads an interspace higher, and the next slide shows the typical ST elevation in V2 with the deep T wave inversion. Can everyone see that?
Yeah.
I think we're good. Okay. So we see the elevated leads now, classical, but this is just minutes following the previous ECG, which showed only the saddleback in V2. So sometimes we have to unmask it by changing the lead positions. Let's talk briefly about CPVT, catecholinergic polymorphic VT. I could never pronounce it. If someone tries to say it, I pretend I can't hear it. This is a very, very difficult, high-risk arrhythmia, usually exercise-induced, usually bidirectional VT. Sometimes patients also have atrial arrhythmias. There's a high mortality rate. It is related to intracellular calcium overload, usually related to a gain-of-function mutation in the ryanodine receptor RYR2 gene, sometimes a couple of other genes. I won't go into that in general, but we really are looking for RYR2. And here is a ECG of a 16-year-old male referred following a syncopal episode that occurred while playing soccer. This ECG is completely normal. The red light flashing is not the ECG. The red light flashing is that he had a syncopal episode while playing soccer. So we have to do our best to reproduce the situation in which he had a syncopal episode. So that would be an exercise test or a monitor while he's active, and that's what we do. So we unmasking again the invisible. It's only invisible because the situation isn't right. Here's his exercise test. And at the beginning, we see bidirectional couplets, VT, and this is really stage 1 on the treadmill. And they typically get ventricular ectopy early. This is while horsing around with his girlfriend on a Holter monitor. Do not ask me what horsing around means. That is what was in his diary. Once again, we see bidirectional couplets. We see some sinus beats in there with lots of PVCs. Clearly a very, very abnormal Holter. And I would go so far as to say pathognomonic in this particular 16-year-old boy for CPVT. So it's really important if you have a history that worries you, especially if the history is associated with exercise, to reproduce the situation in which the exercise or the arrhythmia might have occurred. In his case, a 16-year-old playing soccer. Okay. Lastly, I'm going to touch upon genotype-phenotype correlation. I went backwards on this one, but I ultimately go forwards from phenotype to genotype. She presented to our clinic about 3 weeks ago, and it's a 66-year-old woman referred for an ICD on appropriate guideline-directed medical therapy. LVEF was 21% on MRI, RVEF was 38%, and the MRI said mid-wall late gadolinium enhancement involving septum and inferior wall basal to mid. So clearly a very abnormal test, some form of cardiomyopathy, and sent for primary prevention ICD based on this. So she's in my clinic and I ask her about family history, and she says her sister has a cardiomyopathy and has a CRT ICD device. And I said, oh, was there genetic testing in the family? And she said, yes, there was, but I don't know the result. I guess they didn't know what to do with it. So this tells me there was probably a VUS or a negative test. But I wondered about whether there was a variant of uncertain significance, which was not carried through to the family. Here is my patient's ECG in clinic a few weeks ago. And what it shows is a very long PR interval and a very wide QRS with a very wide left bundle branch block. So very interesting. She basically has, we know that her sister has a CRT, so probably it was thought at the time, I'd never seen her sister, that the sister required pacing as well. So we do have a family phenotype. And at the time, I actually postulated that this was going to be an LMNA genotype. And we did finally get that the sister has a variant of uncertain significance in the LMNA and lamin gene. So it's a laminopathy. The phenotype fits, the genotype fits. And I wonder whether the phenotype now with this ECG makes this VUS into a likely pathogenic or pathogenic variant. I'd be interested in both in Habib and Simon's and Julie's comment on that. So in summary, many inherited arrhythmia conditions require unmasking using pharmacologic, exercise, or non-standard lead positions to demonstrate the classic diagnostic ECG phenotype. Remember, the phenotype genotype correlation goes even for the ECG. The ECG is often the #1 piece of the phenotype in these patients. So I want to thank you for your attention to that. And back to Simon.
Thank you so much, Dr. Green. I'll just let you get that you mute your microphone. Dr. Alqarawi, good to see you. It's my great pleasure. Dr. Alqarawi and I were fellows together here at the Heart Institute in Ottawa, and he was briefly on staff here before returning back to Saudi Arabia. He's an electrophysiologist, he's an assistant professor, and he's just become the head of the National Centre for Sudden Death in Saudi Arabia. So congratulations, Wael. As always, it's a great pleasure to have you here. So thank you for joining us.
I unmuted Simon, because I wanted to say hi to Wael, who I haven't seen in a long time, and I'm going to wave to him. And it's wonderful to have you on board for this, Wael. It's just a pleasure for me, for Simon, for Julie, all of us who know you. Great to have you here.
Thank you very much. It's truly my pleasure to see you guys. Thanks for the invitation. All right. So thanks again for the invitation. It's truly my pleasure to be with you. So what I have is I have two cases. One, which I think I know what's going on with the patient. The other one, I really don't know. So it's great to get your opinion. I do have lots of ECGs, so it should be fun. I have no disclosures. The first case is a 30-year-old female who had breast mass, was seen by a medical oncologist. She had extensive workup, including whole exome sequencing, which identified a pathogenic variant in KCNQ1. This is her baseline ECG. I'm just going to give you a minute to look at it. This is a zoomed on V5 just to calculate her QT. I don't know if you agree, but I got a QT 400, corrected QT of 459, so essentially normal. And then when you talk to the patient, she has no personal history of syncope or palpitation. There's no family history of long QT or sudden cardiac death. She had echo and Holter, which were normal. The question is what to do next. You have this secondary finding or incidental finding of a pathogenic variant in a gene associated with lung QT1, but a normal baseline ECG. And as Dr. Green nicely explained, sometimes we have to provoke ECG changes. So that's what we did. We did the treadmill exercise ECG, and I'll show you some ECG. Unfortunately, I don't have the baseline standing. So I have, this is the 1 minute ECG. This is 2 minutes ECG. 3 minute. This is peak exercise. This is 1 minute recovery. Two-minute recovery. And 4 minute recovery. And I think you can see in this 4 minute recovery that the QT, the corrected QT is about 468. Clearly an abnormal response to exercise. This is the algorithm that was suggested with a reasonable test characteristics for lung QT syndrome. And the numbers you need to know is the corrected QT at 4 minute recovery of 445 milliseconds that would suggest an abnormal response to exercise, suggesting lung QT syndrome. But also stress ECG can be helpful to suggest the genotype, where at 1 minute recovery, if the corrected QT is for 60 milliseconds or more, that would suggest lung QT1. Maybe we'll have a chance to discuss why that is in the Q&A. So if you go back to 1 minute recovery, now I don't know if Dr. Green can comment. I find it hard to know exactly where the T ends, but
I'd go so far as to say impossible. Not just hard. I mean, reading exercise in ECGs when the heart rate gets very fast, impossible. Having said that, it is important that if you can do it, the correction probably should not be Bizet's.
Fair enough. Yeah, and this is part of why the algorithm suggests using 4 minutes, because the heart rate is slower, so it's easier to actually measure the QT when the heart rate is slower. Okay, so that was the first case. I don't know if you guys have any questions or comments.
I have a question.
Yeah.
Why did she have whole exome sequencing for breast cancer? Don't they just do, I'm not a cancer, I don't know anything about cancer genetics, but don't they just do the breast cancer genes? I mean, we wouldn't do whole exome sequencing for syncope.
Yes. Yeah. I don't know if this was...
I'd be interested in Julie's comment on that too.
Yeah. It might have been part of research, but I actually don't know exactly.
Yeah, this is exactly what we were talking about before, as being like an incidental finding that increasingly shows up, and why we can't just turn them away and say, well, there's no family history, there's nothing too suspicious, and they warrant further investigations. But you know, you wonder if we can risk stratify her the same way as someone who had come with an incidental ECG or an incidental event, because this is a completely different kind of incident. It's a genetic incident finding.
Yeah. Good. Any other comments or questions? Okay. So the next case, which is a little bit more challenging. So this is a 34-year-old male who presented with palpitation. His palpitation is worse with exercise. Never had any syncope. There's no family history of sudden cardiac death. He had an echocardiogram, which was essentially normal. His Holter was reported as monomorphic PVCs. I'll show you it's not really monomorphic, maybe not, with some runs of non-sustained VT with a PVC burden of 15%. So he was actually referred for ablation. This is his baseline ECG, and I'll just give you a minute to look at it. So we don't see any PVCs here, but we see T-wave inversions in V1, V2, V3. There's also this abnormal P-wave, which I don't know, the green, what do you think? But maybe this is some atrial myopathy or something. I have another baseline ECG where the P-wave is fine, but you still have this T-wave inversions from V1 to V3. Again, no PVCs.
Some subtle early V-pole as well in the infralateral leads, isn't there?
Yeah.
It's very subtle, more in the last ECG, but
yeah.
Would you, if you go back in ECG, the funny T wave in V2 and V3 ends up with a late wave, which is not a typical U wave. And I'm just wondering, would you call it a U wave? I think I would have to, but it is funny looking. I'd be interested in anyone's comment on that.
Yeah, no, it is a funny, consistent. Yeah, I don't know what to make of it.
yeah, I'd call it a U wave, but I agree. By definition, I'd call it a U, but it looks funny.
Okay, so these are some strips from his Holter. And you see these runs of non-sustained VT, but I don't know what you guys think, but they're not really completely monomorphic. Wouldn't you guys agree? Like these 4 beats of non-sustained VT?
Yeah, I would agree. They're not monomorphic.
Yeah. But the isolated PVCs are all same morphology, essentially. This is another a bit longer run with fairly similar morphology. So because his symptoms were mainly during exercise, we decided to do an exercise ECG. This is his baseline. Now you see some PVCs. We don't have them in all leads, but they're compatible with outflow PVCs, at least from what we have. And again, you see these T-wave inversions.
Mm-hmm.
This is stage 1. And now you have some PVCs with different morphologies. This is peak. There's lots of artifacts, so hard to see much. But then 1 minute recovery, we start having more PVCs. Again, I think these are compatible with RVOT. PVCs. And then 2-minute recovery, we get this. This is certainly not monomorphic, non-sustained VT, but polymorphic. In fact, maybe the axis actually is alternating, especially in this one. But clearly, ugly-looking polymorphic VT. 2 minutes into recovery. Any comments about this?
I think it's very
I
interesting.
think you said it exactly. It's ugly-looking polymorphic VT. It's interesting that it occurred early in exercise and early in recovery, but not at peak exercise. I wouldn't say that is a specific phenotype feature, but it is certainly seen in CPVT for those who, and some of the, so in other words, you can overdrive CPVT at high heart rates. And it starts, you know, in early to mid exercise, and then it appears again afterwards. But it's an unusual morphology for, I mean, it's not typical CPVT, but it's just interesting that it occurs in early exercise and early recovery and not in between. Obviously, I would want to know, firstly, is there a cardiomyopathy? But I would also be looking at a specific channelopathy.
The thing that's hard to explain, Wael, is that the changes on the resting ECG, because in my mind, when you see this in early recovery, it's more like CRDS. You know, you don't see it during the peak of exercise you'd expect with CPVT. You could do a burst treadmill and see if you could do it. But there is overlap into CRDS.
I'm not sure that everyone knows what CRDS here, Simon. It's a relatively new description, but yeah. It is. Go ahead.
No, I mean, classically what they would say, so for calcium release deficiency syndrome, what you would usually see is this complex ectopy, not during peak exercise, but you see it during early recovery. And it looks very much like the ectopy you get with CPVT, where you have bidirectional couplets and that same pattern, but rather than being during the peak catecholamine surge that you get with CPVT, with CRDS, you see it more during the recovery stages. But what wouldn't fit is that he looks on baseline ECG like he has structural abnormality with the precordial T-wave change, although the MRI was normal, which would be unusual. He also doesn't have a classical history of CPVT given his age and the fact he's never been syncopal in the past.
Yeah. And as you said, Simon, I'll just show you one more. So this is 3 minutes, and it's even more ectopies. You know, so, and then this is 4-minute recovery. Lots of ectopies. And we had to wait, let me see, I think 10 minutes in recovery, and he's still having some PVCs, but clearly not as many. So we then did MRI, which was completely normal. His genetics are pending. And the question is, what's the diagnosis? And I agree, you know, this the abnormal baseline ECG is a bit confusing. I don't know. You know, could this be ARVC? And you know, sometimes you don't get the MRI changes early on, or is this not ARVC?
I mean, I've seen something, I call it pseudo-normalization of these T waves during exercise and recovery to be much more closely linked to cardiomyopathy. ARVC is definitely a possibility, but then you also get some non-RVOT-like morphologies in your PVC. You know, going back to my talk, that's what I'm going to bank on. LV non-compaction first, but we'll see.
It's a good question.
Would you would LV non-compaction with a normal MRI?
Well, yes, it depends on who's read the MRI. So I read the MRIs myself. So
maybe I'll send it to you, Habib.
Yeah, no worries, Wael, anytime.
So that's a great question. I think MRI depends who reads it. So I did ask for a second opinion on his MRI just for that reason, and repeated his MRI within just to see if there is new changes.
I still think it's possible. Like I for sure would chase cardiomyopathy, but the funny U wave, I don't know what that is. Typically with KCNJ2, you do see this kind of ectopy that mimics CPVT. It comes late. I don't know, but if you came up with a VUS in KCNJ2, I might be interested. I'm not sure that it would be uncertain significance. I'd probably have to look up the electrocardiographic phenotype more. But this is strange. I would still chase cardiomyopathy, but if you couldn't get it and you get something in the genetic, either RYR2 or KCNJ2, if it's RYR2, it might be a loss of function mutation, which is going to be CRDS, calcium release deficiency syndrome, or something else. Really strange.
What do you think about the presence of RVOT PVCs during exercise? I think if you stress most kids, I think when I did some pediatrics and we stress kids for CPVT, it's very common that during early stages of exercise you see ectopics coming from the RVOT, but they're not often related to the ectopics you see later on during peak workload that trigger these kind of torsades, if you like. So I don't know whether, do you think that the PVCs you're seeing from the RVOT were part of it, or do you think they were just kind of benign bystanders?
Yeah, I don't know. Now, if you look at his Holter, I didn't show you everything, but he does have PVCs at baseline that probably are VOT. So it might be not part of this, as you said. Hard to know.
And do you know if there's any evidence of, let's say, looking at RVOT ectopics pre-exercise and post-exercise and recovery? Is there a link to increase in burden of PVC in recovery to cardiomyopathy or pathological mutations, as opposed to the baseline?
Sorry,
so on your Holter, let's say if you're having a PVC burden of 3%, but you stress them and in recovery, you saw the ECG is quite ugly looking towards recovery, where it took 10 minutes for it to get down to baseline. That certainly to me looks like a more aggressive form of RVOT ectopics, because usually that's not how they behave, right? I mean, you stress them, you get them a little bit early, but then the RVOT ectopics would fade away, you get nothing at peak, and then it'll be pretty much normal until you get to baseline when you start getting RVOT ectopics again. But in this case, it was the other way around. You had a lot more aggressive recovery rather than baseline.
Yeah. Well, I certainly think what we saw in early recovery is not the benign outflow PVCs. I just don't know if there is this incidental or not related RVOT PVCs on the background. That I'm not sure. But I agree, like the behavior of these runs in early recovery is not what we see with benign RVOT PVCs.
And you've asked for both cardiomyopathy and sort of electrolyte panel as well.
Well, actually, yeah.
Sorry.
Yeah. The other thing is screening the family. Sometimes clues from family members, so we'll see. It'll be interesting.
Yeah, that's fantastic.
Are we going to find out?
At some point.
That means you gotta get back to us, man.
Yes, I will.
Not today.
Not today. How long does it take to get genetic testing results in Saudi Arabia?
Ooh, long time.
Even if you're the director of the sudden death lab for the country, still takes a long, takes a long time here too.
Yeah, probably 5 to 6 months. It will get better. Well, but for now, it's a long time.
I think as a general comment as well, Wael, it's probably worth mentioning to other people maybe who are listening that RVOT PVCs are exceptionally common, and the vast majority of them are not associated with other forms of disease. They're idiopathic and benign. We're focusing on them a little bit more in this case because clearly there's something else going on, but we don't want to give the wrong impression that PVCs from that area are often pathological.
Yeah, I agree.
Fantastic. Okay. Any other questions? Do anyone else, any of our participants, any other questions? There's nothing in the chat right now, but feel free to raise a hand or to put a question in the chat for any of the panel.
Can I ask a question? Am I allowed to ask questions?
Of course.
So the making diagnosis is one thing, but also deciding on what to do with a patient is a completely different thing. You know, he's on beta blocker. What would you do? How would you handle the issue of ICD with this patient?
You know, if it's not a cardiomyopathy, but rather some form of channelopathy, even if you don't get a diagnosis, beta blockers are going to be the first treatment anyway. So yet we know in long QT, we know in CPVT, which typically are exercise-induced arrhythmias, how effective beta blockers are. So I would, if he doesn't have a cardiomyopathy, if he does have a cardiomyopathy, you're going to start him on a beta blocker anyway. But if he doesn't have a cardiomyopathy, I would say it is probably adequate treatment, and I would put him back on the treadmill and back on the Holter and do all those things on good doses of beta blockade. And if everything disappeared, I'd probably say, you know what, I think we found the treatment.
Wael, what do you think about the role of invasive testing? So potentially the role of long short sequences, EP study, mapping of the RVOT, looking at endocardial, epicardial voltage, unipolar voltages to see if there's anything else there for the substrate.
Yeah, I mean, it might be helpful if it's positive. I think if we do voltage map of the RV and it's normal, it might suggest cardiomyopathy. But if it's not, if it's going to be helpful.
I would argue it might not be helpful if it's positive. I don't know what the sensitivity and specificity of that test is. Who do we test? We test people who have heart disease and inducible VT. So where's the experience going to come in terms of voltage mapping, in terms of how that's going to change our prognosis and what's normal? I'm not sure that it would be helpful. If you induced monomorphic VT, that would be helpful. Anything else, I'm not so sure. His arrhythmia is not monomorphic VT. So again, I don't know where you would go with it.
No, there are research algorithms.
Personal opinion.
There are research algorithms for CRDS to try and make diagnoses. They're for research application only, not for necessarily for diagnostic purpose. But there are algorithms. So I think Jason Roberts now has an ongoing study looking at this. So they have a specific sequence that they do for pacing from the RV and look at the classic response for it. But it's it's a research tool. Oh, I think you're muted, Dr. Kuhn.
You're muted.
Sorry, that's unproven. It's research. We don't have a sensitivity and specificity. It would not be enough at this point to go forward with anything. And it's only done in people who have documented loss of function RYR2 variants. So I would argue against doing that without more information. Not there yet.
No, I'm not advocating for it at all. It's purely as a discussion topic in an unusual case.
We're currently looking at burst stress testing as well, right? The burst protocol for CRDS. I mean, that might be something that might prove useful in the future, but as Wael already pointed out, it's in research phase. The only other comment I have about voltage mapping is there's a case pretty similar to this. He was a basketball player, quite young in his 20s, with no previous history of any family history, but had monomorphic VT. Came into hospital, had a normal, well, a little bit of regional motion abnormality, mildly dilated RV that you sometimes see with athletes. He was playing at the provincial level of basketball, so you would sometimes see that in cardiac MRs. And then we subjected him to have an EP study while waiting for genetic testing. So when EP study kind of showed he had RVOT as well as RV free wall low voltages, that would suggest that this was ARVC, although he did not fulfill the MRI diagnostic criteria. And then he had his genetic results come back 2 months later that showed a PKP2 mutation, but of VUS. And, you know, we never got down to, you know, it's kind of segregating this in the family because he refused further testing, and so did the family. That there were, I think, from Somalia or Sudan, where maybe it's a little bit of a taboo to undergo genetics. So there's a little bit of this sort of disgruntled family affair. So I don't know, maybe in certain cases, you know, voltage maps and EP studies can be helpful, particularly with cardiomyopathy sort of issues. Not probably so much with channelopathies, because when we do voltage mapping, they usually come out normal. So there probably has a role, but it has to be a very selective patient population.
Yeah, I mean, you know, some people advocate for using voltage and including it in the task force for ARVC because it's a little bit more sensitive. But as you said, you can't use it for everyone, and you have to be careful because, you know, other things can cause low voltage.
Yeah. Okay.
Fantastic. Thank you, Wael. Great presentation, very engaging discussion as well. So thank you. What time is it there now? Midnight?
12 minutes before 4, and people have to be off at 4.
Yep.
So we have a few minutes for questions if there are any more questions or comments.
I was going to ask you a question, if that's okay. One of the fascinating things about inherited arrhythmia is looking at the ECG and then making a phenotypic diagnosis and linking it back to a genotype. And it's nice when it works, but we know that there's often an overlap. So what's your feeling about that?
Well, you know, I totally recognize that the ECG is not going to be the only diagnostic tool in this inherited arrhythmia world. And I think the phenotype, even when it includes the ECG, is also going to include other pieces. It's going to include family history. It's going to include, does the arrhythmia occur at rest or during exercise? It's going to include, has anyone dropped dead? What are the circumstances around that? It's going to include the MRI for sure. You know, is there evidence of structural heart disease? So I'm one of those guys who would say the phenotype includes all of those things. And I can't imagine proceeding without trying to get all of those pieces of the puzzle to help me, both with the diagnosis and with the advice and the therapy. I see Julie's got her hand up there.
Yes, you had mentioned about your case with the woman who presented. and her sister had a previous testing and had found a VUS in Lammin, and that you were suspicious of Lammin just based on the ECG, and you wondered whether this additional diagnosis in the sibling who is affected will change the VUS status. I think it likely will. It does show the power of segregation. Because without that segregation, we wouldn't have that data. All we would have is one person with a VUS. It was a suspicious VUS at the time because they're the same allele. There is a publication about a family of two people who had some signs of dilated cardiomyopathy. So I think this combination, that will give it an extra score in our scoring system, and is important then for future patients that come down the road for this as well. So it's really important.
Yeah, I mean, if it looks like LMNA and it smells like LMNA, and there's a family history and a variant in there, and they both have the same ECG, it really is going to add to where that VUS ends up. I think it has to. I totally agree with you, Julie.
It's an interesting thing, isn't it? What makes a VUS? And once you see clustering, familial clustering, it's probably no longer a VUS.
With the VUS, I mean, Julie's here and Brianna's on. Julie, it's a VUS because it's inadequate information to go either one way or the other. I think nothing more, nothing less. They don't have enough to place it in one of those categories.
Right, and that's often the definition. I mean, there's lots of gradation within that bucket of VUSs. Is really, there are some that are much more suspicious. It was already on the suspicious end of the spectrum because of this allelic change that was found there. But this will, probably push it over. But you have to keep caution with that because they're siblings. They share half of their DNA, so they're going to have the 50% a priori risk that they carry the same VUS. So it's really the addition of you saying, listen, this ECG, this phenotype fits this genotype, goes a long way. Because if it was in a different gene, if it was a channelopathy gene that they happen to both have a VUS in, that wouldn't, make the points adding up to why we should change this from a VUS to a pathogenic.
Yeah, that's a really helpful comment to guide us as well. Along that same line, Judy, what about variation between labs? Who's calling it a VUS? Whether one is, one isn't, where that's recorded. So just for people who are listening who may not understand how these things are defined, could you explain a little bit about how there can be variations and distinctions between what some people may call a VUS and others wouldn't?
Yeah, so keeping in mind the caveat that I don't work in the laboratory myself, but in genetic testing, there is now since 2015, the American College of Medical Genetics has a standardized system to evaluate variants, and it takes into account a lot of different aspects, including the past medical literature, and different aspects even in the past medical literature. Did it show that there was functional data? Is there data about segregation of variants? What do we know about this gene and the variations and tolerances? What do we know about the types of changes in the gene, whether it's a loss of function, gain of function? So there's a lot of data that goes into a scoring system, but even with that standardization, there is still room for interpretation because someone might review this and say, well, I don't agree that that was a good functional study, or this is not sufficient data that shows the segregation, or they might rule out a paper to say it was so many years ago, maybe we shouldn't consider that as accurate information. So you can get, even 2023, the same variant will be assessed by two different laboratories and come up with a different answer. And so that's where it really takes the clinical judgment then to go back through the data, speak with the laboratory scientists, speak with the clinicians, and it's really a team effort And it's a difficult situation, I think, because you know, it's up to the clinician in a way of how you're going to use that information. And there's definitely hazards in both directions if you consider it disease causing, and therefore you use it to segregate people in the family about who needs to be followed or not, or ignoring it and saying it's only a variant of unknown significance, we shouldn't use that. So it's not straightforward, and you have to know the lab you're working with, and that's also why you need to go back to that lab as more time and more information is gathered.
Yeah, that's fantastic. Thank you so much. It's now 4 minutes to 4, so we're going to bring this to a close unless there's any other questions people would like to ask. Can I just take this opportunity to thank everyone who has attended, everyone who's joined us for this meeting, and thank you so much to the speakers. Wael, thank you for joining us at the end of your day. Thanks, Habib. Thanks, Julie. That's great. Thank you, Dr. Green. It's been a great meeting. Very interesting. Good presentation. Thank you so much.
Thank you so much.
Thanks, guys.
Thank you, Simon.
Thanks.
And thanks, Wael, for, is it midnight?
It is 3 minutes to midnight.
Thanks for being here with us.
Oh, thank you. Good seeing you.